Okay, welcome to the 2023 Live Smart Texas World Obesity Day Summit, and thank you for joining us. My name's Leah Whigham, and I'm here today with my co-chair, Emily Durander. We are co-chairs of Live Smart Texas, and we will be running the webinar today. I'm also the director of the Center for Community Health Impact and associate professor at the University of Texas Health Science Center at Houston School of Public Health in the Department of Health Promotion and Behavioral Sciences, and I'm based at the El Paso campus, although today I'm broadcasting from the Austin campus. Before we get started, I just wanted to make some housekeeping announcements. This webinar will be recorded and will be archived along with the presentation slides on our website at msdcenter.org. If you have any questions during the presentation, please enter them into your question box. We will have time for Q&A at the end of each round of presentations. Today's webinar is hosted by the Michael and Susan Dell Center for Healthy Living at the UT Health School of Public Health in Austin in partnership with Live Smart Texas. Live Smart Texas is a coalition of organizations and individuals who work together to address the state's obesity epidemic. More information on this slide can direct you to our website, and Emily Durander and I are current co-chairs of Live Smart Texas. Today we're going to be talking about obesity. Obesity is a complex disease with a multitude of causes and contributing factors. The causes of obesity are rooted in the body's dysregulation of energy storage, which then leads to excess fat storage. In other words, obesity is caused by an inability of the body to maintain fat storage in a healthy range. In our world today, there are also many contributing factors to obesity. These include many environmental and social contributors that interact with the causes within an individual to make maintenance of a healthy body weight even more challenging. In order to address obesity effectively, we must act on both the causes and the contributors. Importantly, we must not blame the individuals affected by the disease, but instead work together to find solutions. The mission of World Obesity Day is to increase awareness, encourage advocacy, improve policies, and share experiences. You can find more information about World Obesity Day at worldobesityday.org. This is also Obesity Care Week, and to address Obesity Care Week has been organized by a group of partners to address a lack of appropriate science and clinically based care. The organizations who have come together to organize Obesity Care Week include the Obesity Action Coalition, the Obesity Society, the Stop Obesity Alliance, the Obesity Medicine Association, and the American Society for Metabolic and Bariatric Surgery. Obesity Care Week has a vision to create a society that understands, respects, and accepts the complexities of obesity and values science and clinically based care. Obesity Care Week will achieve this vision to change the way we care about obesity. You can find more information at obesitycareweek.org. There are activities going on throughout this week, and you can find more out about those activities on the website and through social media. So today I'm excited to share with you our Live Smart Texas World Obesity Day Summit, where you will learn more about all the aspects of obesity in Texas. We are so fortunate to be able to start off today with a keynote address by Dr. Sarah Barlow, and following the keynote, Live Smart Texas Steering Committee members, both regional and organizational, will provide quick updates about events happening in their areas. Then we will learn about the state of obesity in Texas, presented by the Partnership for Healthy Texas, featuring panel experts. And lastly, Dr. Hoelscher, the Regional Dean for the UT Health School of Public Health in Austin, will close out the day with a presentation and closing remarks. So I'm very excited to be able to introduce Dr. Sarah Barlow. We've known each other for many years, working as colleagues and collaborators in the field of obesity. We're so privileged to have her today to give her talk entitled The New American Academy of Pediatrics Child Obesity Treatment Guidelines, the answer to what is the one thing we can do to address this problem. And I will turn it over to Dr. Barlow now.
So I've worked with the AAP to create a slide deck that we've been sharing across the different people involved. But I have added some of my own slides that are in the children's UT Southwestern format, and that's just to highlight the fact that those slides are not necessarily AAP approved. Really, it's just giving some additional research background for some of the action statements that were made. Next. So everybody on this call knows that obesity is a very, very prevalent and important problem, with now over 14 million children and adolescents in the U.S. affected by obesity. Next. And it affects not only the long-term health of children, but the immediate health. Next. And this includes diseases like type 2 diabetes, hypertension, non-alcoholic fatty liver diseases. These are all metabolic diseases, also sleep apnea, and also mental health, including depression. Next. So I want to really highlight why the CPG is different from prior statements around the treatment of obesity. Next. The 2007 recommendations, that's 15 years ago now, were really a different process because the state of the science was different at that time. These started with a series of meetings convened by the American Medical Association, the Maternal and Child Health Bureau from HRSA, and the CDC, with a plan to update the original recommendations from 1998. And the expert committee actually comprised representatives from major professional organizations that all had a vested interest in the various aspects of childhood obesity. Next. The expert committee appointed writing groups, 3 writing groups, one for assessment, one for prevention, and one for treatment. And within each group that had maybe, 7 or 8 people, the group was tasked with reviewing the literature, although it wasn't a librarian-focused systematic review, developing recommendations, and then writing them. Next. And this resulted in, a supplement with a paper on assessment, on prevention, on treatment, and a summary paper. Next. And, these are recommendations, but it's expert consensus as opposed to a strong evidence review. In contrast, the current clinical practice guideline development was a much more comprehensive process, and it took 5 years, starting in 2017. Next. So the first step was the evidence review, and this was quite a massive undertaking, reviewing literature back to 1950 and creating technical reports. Next. So there were 2 key questions. One, what are the clinic-based effective treatments for obesity? And key question 2, what is the risk of comorbidities among children with obesity? This initial research period ended in 2018, but there was an update in 2020 so that the publication would be as up to date as possible. Next. Then the subcommittee examined these technical reports and developed an outline for the CPG. Next. With that came evidence grading and key action statement recommendations, along with a narrative. And the key action statement grading followed the standard approach, which is giving an A, B, C, or D level for the evidence quality, and then a recommendation of strong, moderate, or weak, balancing the benefit or harm of the recommendation. Next. And then finally, there was an internal and external review. So that's why this took so long. And I want to point out that this focus is on treatment of obesity. It does not focus on prevention. The American Academy of Pediatrics is actually in the process of a review and will present a paper on that probably late summer or fall. Next. And so January 9th, this was published, 100 pages, and if you want the executive summary, that's about 10 pages. Next. So just over that 15 years, the systematic review started with 16,000 abstracts, leading to 1,600 full-text articles, and then inclusion of 318 studies, the 2 technical reports. There are some consensus recommendations when there was not appropriate evidence to rise to the level of a key action statement, and then there's 13 key action statements. Next. And this was obviously a huge undertaking. The evidence review and reports was led by Ashley Skinner. Next. The CPG subcommittee that graded the evidence and wrote the paper was led by Sarah Hampel and Sarah Hassink. Next. And of course, the AAP was key in keeping us on track for this very rigorous process. And the Institute for Healthy Childhood Weight has provided some great support so that some implementation material has been available immediately. Next. So the key takeaways, as Leah said, obesity is a complex chronic disease. It's important to do an evaluation that is comprehensive and takes into consideration the whole child. Obesity treatment is safe and effective with a good evidence base. And treating obesity also means treating comorbidities. The other point that is, I think, different from the recommendations is that there's really an urge to make sure that when a child is identified as having overweight or obesity, they should be offered treatment immediately without a watchful waiting. The 2007 recommendations got a lot of attention and were somewhat innovative because in addition to recommending approaches, there was a presentation of a proposal really for how to implement it, where and how to provide treatment for children, balancing the high number of children that really entailed involvement of the primary care pediatrician, at the same time acknowledging that the primary care pediatrician would not have the capacity to deal with more complex treatment. And there was this staged approach that really appealed to a lot of people, but honestly, as somebody who was part of that treatment, there was no evidence behind that. It was kind of completely expert consensus. And so that slow delay, start low, wait 3 to 6 months, move on to the next level, there's really just no evidence for that. Really, we just see that the weight gain is likely to continue. Next. So the foundation of evaluation and treatment is really understanding that underlying genetic, biological, environmental, and social determinants that lead to obesity. Next. And I think people will be familiar with the socio-ecological model where the child's genetics, the child's biology exists within the context of a family and the family organization and values, and that exists within the community and also within the larger society with the policy and various aspects of the environment that are influential in how the child is living. Next. Another important factor that the CPG really paid attention to is the association that's seen between ethnicity, race, and obesity and its comorbidities. And that really race is not a biological construct, so that relationship most likely reflects epigenetic, social, and environmental factors, including the social determinants of health, such as limited food access, low socioeconomic status, exposure to structural racism, neighborhood deprivation, and so forth. Next. And so really, obesity is often an indicator of structural inequities like unjust food systems and environmental and community factors. And all of these things, genetics, the environment, the life experience, combined with the inequities and barriers to healthy living are all contributors to overweight and obesity. Next. Okay, so let's move on to the CPG and the recommendations. Next. So the first key action statement is BMI measurement, that pediatricians should measure height and weight, calculate BMI, and assess the percentile using the age and sex-specific CDC growth charts. Next. Quick review. These growth charts were created from data before 1980. So this distribution of body mass index reflects what we think is a relatively healthy distribution prior to the onset of the obesity epidemic. And so unlike adults, the norms change based on sex and age, and we talk about not BMI, but BMI percentile. The dark line that I overlaid is the 85th percentile, which represents the cut point between what is considered a healthy BMI and overweight, and the red line is the 95th percentile, which is the cut point between overweight and obesity. And we do have to remember that this is we use obesity as a medical term here. Children just above this may not appear visually as having particularly high weight, but this is a point where there's higher adiposity and higher risk of health consequences. Next. But, you know, with the obesity epidemic, it's now 20% of children are above the 95th percentile. And so we have needed to add additional ways of measuring besides percentile, because we run up against that 99th percentile roof on the growth charts. So this is really the same growth chart. It's just that the y-axis has been extended from a BMI of 35 up to a BMI of 60, which kind of squishes down those curves. But that 85th percentile curve is still there, which I've marked in the dark blue, the 95th in the lighter blue. And then we start talking about a severe obesity cut point at 20% above the 95th percentile, which is that dotted line. And in fact, I'm not showing it here, but there is a class 2 obesity as well, starting at 140%. Next. And so the prevalence has increased. This is a 10-year increase from about 18.5% to 21.5%. And this is 2020 data, which is pre-pandemic. So we haven't seen it yet, but we're anticipating kind of a big jump with the next round of NHANES. Next. We know that obesity prevalence increases with age from preschool to elementary to adolescent. And also we see the different risks by race, ethnicity, with about 22% of Black children with obesity and 26% of Hispanic children. Next. And the class 2 and class 3 obesities represented in the dotted lines are also rising along with the overall obesity rate. Next. Okay, so there were a number of key action statements in the CPG about evaluating and addressing comorbid conditions. And I'm not going to spend a lot of time on those, except to say that, you know, it is important that in addressing comorbidities, the provider looks not just at the physical, the patient history and the exam and the diagnostic studies, but also addresses mental and behavioral health status and pays attention to social determinants of health as contributors to the weight condition. Next. And also that treating overweight and obesity and comorbidities should occur concurrently, because in fact, treating obesity is the way that you address many of the comorbidities. Next. Because it's clear that obesity increases the risk for comorbidities and that weight loss interventions can improve them. Next. So there's some an algorithm that the AAP made to really synthesize the different recommendations around screening and treatment for each of the common comorbidities associated with obesity. Next. And this is just an example of some of the support material that the AAP has created for providers to guide the care of those comorbidities. Next. Okay, moving on to treatment recommendations. KAS 9, I'm jumping ahead here. This is really an overarching treatment principle of using the medical home and the chronic care model principles to address obesity. So what is the medical home? It's primary care that is patient-centered, respecting patients' needs and preferences. It's comprehensive, so it's not just taking care of illness, but wellness and prevention, physical and mental conditions. It's coordinated with other healthcare and community services and is accessible. And the chronic care model is very similar, but it's saying that when there is a chronic condition, we need to take an approach of organizing the care for the chronic disease that is patient-centered and, encourages self-management and use of other resources outside the office visit. And so this is an important kind of philosophy about taking care of this chronic condition. Next. And this figure kind of captures the, I think the goal of care, which is that the patient and family should be in partnership with the providers. That dotted line and the squiggly line represents the fact that obesity care is really chronic care. Treatment intensity and support are going to vary because obesity is likely to be relapsing and remitting over time and not a condition that responds to one intervention 1 year. So we want shared decision-making with the patient and family. We want culturally competent care. The medical home should be the coordinating center because they have that longitudinal relationship with the family with a plan for transition when they reach adulthood. And understanding and appreciating all the pressure, the structural and contextual factors that really impede health and treatment, including access, the obesogenic environment, the stigma, the racism, and the health inequities. Next. Okay, next key action statement is using motivational interviewing. Motivational interviewing is a technique which helps the provider uncover the family or the child's own reason for making change. And this, of course, doesn't exist in isolation. Motivational interviewing is used to help the family identify their priorities, whether it's behavior priorities, whether it's a decision about medication. And the reason this is a KAS is that even though this technique is actually part of a lot of behavior-based interventions, there were several high-quality studies where the randomization distinguished the two arms by the use of motivational interviewing and showed benefit. And so this is an important foundational technique for providers who are taking care of children with obesity. Next. Okay, KAS 11 is intensive health behavior and lifestyle treatment. So this recommendation is that children who are 6 and older should be provided or referred to the IHBLT, and children younger than that may be referred or provided with that kind of treatment. And the may is with a less strong recommendation is because there's less data for this age group. It also needs to be intensive because the data shows that health, behavior, and lifestyle treatment is more effective with greater contact hours, and 26 seems to be the magic number. Next. And this is data that does not come from our technical report because there wasn't a nice figure for that, but the impact was, or the findings were pretty much the same. This is from the U.S. Preventative Services Task Force. And this looked at 36 high-quality randomized controlled trials arranged by hours of contact. And you can see with the forest plot on the right, the line being neutral effect, that the studies that were, for the most part, to the left of the line, meaning that there was an impact in the favorable way, it really starts at 26 hours. So 26 to 52 hours, there's an impact, and greater than 52 hours is really substantial impact. And so that's where this recommendation comes from. Next. The characteristics of IHBLT are components that include eating and nutrition to establish healthy, sustainable patterns, so not very low-calorie diets or unbalanced macronutrient diets, but healthy, sustainable patterns. Also addressing physical activity, again, to establish healthy, sustainable patterns. Behavior change strategies, so teaching families things like changing the environment, monitoring, goal setting, and engaging the family. This IHBLT should involve the whole family and not address the child by himself or herself. Again, this should be offered upon diagnosis. The format can be group or individual or some combination. It could occur in a healthcare setting, but it also could occur in a community-based setting with linkage to the medical home. Again, that 26 contact hours. And although data on virtual implementation is sketchy, it's limited. At this point, it seems appropriate to consider virtual as well as face-to-face. Next. One of the things that is not included in the KASs is recommendation around very specific behavior strategies, and that's because it's really hard to measure the impact of any particular strategy in a group. Next. So specific strategies include things like reducing sugar-sweetened beverages, eating breakfast, ensuring appropriate sleep. We know that there's an association with improved weight and better health with these, but a randomized controlled trial that teases out the impact of each one of these is really would have to be absolutely huge. So although there's some consensus recommendations about this, there are not key action statements about this. Next. KAS 12 is pharmacotherapy. Pediatricians should offer adolescents 12 years and older with obesity weight loss pharmacotherapy as an adjunct to health, behavior, and lifestyle treatment. Next. So this is not should prescribe, this is should offer. This should be on the table as a possibility for adolescents. And again, it's not in isolation, it's as an adjunct to health, behavior, and lifestyle treatment. Next. And this is the data behind it. There's been 2 weight loss medications that are fairly new in adults and have been evaluated rigorously among adolescents and have received FDA approval in the last few years. One is Saxenda or liraglutide, which was approved in 2020 based on a 1-year double-blind randomized placebo-controlled trial of 250 adolescents showing good impact, change in weight versus in the intervention arm versus placebo arm. And Qsymia, which combines phentermine, a very old weight loss medication that was actually first approved in 1959, and topiramate, which is a medication used for seizures and migraine prophylaxis that was approved just last summer, that shows really actually very good impact with good safety profile for these. Next. So just to stress, there's no current evidence that supports weight loss medication use as a monotherapy. All of these studies included healthy lifestyle for both arms. The difference was the arm that received the intervention arm that received the medication. Next. And the final key action statement is metabolic and bariatric surgery, that this should be offered to adolescents 13 years and older with severe obesity. Remember, that's defined as a BMI greater than 120% of the 95th percentile. So I've highlighted a few things. This is not that providers should send the adolescents to the OR. They should offer a referral. So it's, again, a discussion with the family and a referral to a high-quality pediatric, metabolic, and bariatric surgery is really offering the beginning of an evaluation. So a good center that does pediatric surgery does a very comprehensive evaluation and education so the families understand what the surgery means. There's a dietitian that does evaluation to provide support. There's a psychologist. And not every child that gets referred for evaluation goes on to have the surgery. Again, next slide, this surgery is very effective, and there's evidence behind it. It's got a good safety profile, and it's important that families understand that this is an option that may be right for them. So this is data from the NIH-supported teen lab study with outcomes out to 3 years with the gastric bypass, which was the standard of care when this study was started, and the sleeve gastrectomy, which has become the standard of care because it's a simpler procedure, and as you can see, very similar in terms of its effectiveness. Great outcomes over the first year, and overall good maintenance of the weight change. Next. Again, coming back to let's not do watchful waiting. Start treatment immediately and deliver it intensively. At least make that available for families. Next. And again, the AAP has developed material to guide providers, including an algorithm. They can also be used to underlie a clinical decision support tool that might be embedded into an electronic health record. Next. So what's new from the previous recommendations? I think the appreciation that obesity is a chronic disease. Also the appreciation that of the complexity of environment and especially the social determinants of health. And also understanding that weight bias and stigma is pervasive and harmful and can be a barrier to treatment. No benefit for watchful waiting. Treating obesity and comorbidities, comorbid conditions concurrently, because that comorbidity is a result of the obesity, and treating the obesity is a way to address the comorbidities. And that there are many evidence-based strategies that can be used collectively to deliver intensive and tailored obesity treatment. Also, that there are studies examining the impact of weight management interventions on current and future eating disorder symptoms. And a high-quality, structured, supervised weight management actually has been shown to decrease these eating disorder symptoms. Next. There are some limitations and some implementation challenges. Next. So there's a lot of uncertainty for pediatricians, the duration of treatment effects on weight and also on comorbidities. The heterogeneity of treatment effects, the data, the studies show the mean outcome, but if you really tease apart the impact on each individual participant, there's huge variations. And it would be really helpful to understand, who's going to benefit, to develop some more personalized approach. Some of these studies, whenever you do a rigorous randomized controlled trial, it tends to be a more homogeneous population. And so we need to understand how these studies or these programs could be adapted to better serve people from different socio-demographic settings with experience of different social determinants of health, populations with special health care needs, and also different degrees of obesity severity. And further work to understand what specific components and multi-component programs are most important so that we can streamline and provide the most effect with the least time and resources. Next. Really important implementation barrier is the healthcare infrastructure and capacity limitations, especially facing primary care pediatricians. So, we're just, as a healthcare organization, we're just really not set up to provide 26 hours of care. And there's been certainly concerns about that. Also, healthcare coverage. This kind of especially the intensive healthy behavior and lifestyle treatment is not easily covered under our current healthcare insurance system. It's really burdensome on families to participate in IHBLT, and we're now talking about medications to a set of providers, pediatricians, who are not used to that, so we need to sort of help support them in developing that skill set. Next. Okay, this has gotten a lot of attention, and here are a few of the biggest concerns. What about availability? How can my patients get intensive behavior treatment when I might have 15 minutes for appointments? And it's true, the current healthcare delivery and payment system is not compatible with evidence-based IHBLT, but that's what's different about a CPG compared with recommendations. Go ahead and move on to the next slide. The CPG process follows the evidence. Sorry, go back. It follows the evidence. So, and that is a challenge, but it's also its strength, because I think and hope that this will shift the burden to policymakers and health insurance to make this happen, because that's what the evidence shows. So it's really a call for action, and AAP is advocating for programs that are feasible, available, convenient, and covered by health insurance, and other organizations are joining. Next. What about eating disorders? We'll talk about weight trigger eating disorders, and what about body positivity? If you were reading editorials at all, you will have seen this. The community, my community that is working on treating obesity and implementing it and making it available, and the providers that are focused on eating disorders actually share a lot in terms of philosophy, including that obesity stigma is real and very harmful and is prevalent not only in the society at large, but within the medical community, and that's something we really need to address. Also agree that eating disorders are increasing, and that restrictive and fad dieting are associated with eating disorders. Again, as I mentioned before, in the studies that we have, it appears that participation in evidence-based behavior program that focuses on sustained healthy eating reduces the risk of eating disorders. That said, there are some limitations because any type of rigorous randomized controlled trial has some strict eligibility and ineligibility in terms of identifying the participants. And so we need to make sure that that we are doing studies that include children with a range of mental health conditions. Strategies to address this using people-first language, talking about children with overweight and with obesity, or with high weight and not obese children. Focusing on health and behavior change, not appearance or a target weight, but really aiming for overall health. And again, making sure that we're identifying and delivering programs that focus on establishing sustained healthy eating, not low-calorie diets. And then the final kind of major headline was, provide intensive treatment. Does that mean go straight to medications and surgery and forget about the healthy lifestyle? If staged care is no longer recommended, do we just start prescribing medications? Again, health and behavioral lifestyle treatment is foundational, and medications or surgery rely on that foundation. Those are always done in concert with lifestyle treatment. Do not delay addressing weight, and know and use the treatments that are available, but all treatment decisions are individual, made with the family, taking into consideration the values, the motivation, and the situation and context. Again, I'm coming back to this because I think this figure really captures for me the importance of longitudinal care, not a single approach to addressing care, but really working closely with the family for what is appropriate for them and their situation, and really working on accessing care. So the CPG supports early treatment at the highest level of intensity appropriate for and available for the child. And it's hoped that pediatricians and other primary healthcare providers, health systems, community partners, payers, and policymakers will recognize the significance and urgency outlined by this CPG to advance the equitable and universal provision of treatment of the chronic disease of obesity in children and adolescents. That kind of summarizes, I think, the philosophy. So I want to thank you. There is good information if people are interested, especially at aap.org/obesitycpg. That has a lot of the implementation material that people may be interested in. And I think I did okay, and I'm happy to take a few minutes to answer questions.
Excellent job, Dr. Barlow. Thank you so much. We have some questions coming in, and while I give just a moment or so for people to enter more questions in, I'm just going to give a brief professional biography of Dr. Barlow, which we didn't do at the beginning of the session, so everyone knows more about her background. Dr. Barlow's been focused on treating childhood obesity throughout her career. This work has included reporting recommendations of an expert committee in 1997, serving as a member and author of the expert committee in 2007 for new and broader recommendations, and co-writing the treatment section of the new American Academy of Pediatrics Clinical Practice Guideline. That's why she was such a great speaker for us today on this topic. She's a clinician who cares for children with obesity and has been the director of weight management multi-component programs at 2 different institutions. She's especially proud of the work she did as a co-investigator on the Texas Childhood Obesity Research Demonstration Project, a CDC-supported study that addressed childhood obesity through a program that partnered with primary health care and community organizations, engaging low-income, predominantly Hispanic families. Currently at UT Southwestern and Children's Health in Dallas, as the Director for Integrated Programs in Childhood Obesity, Dr. Barlow works with a range of programs targeting healthy weight for children, including community programs, primary health care programs, and tertiary care. A priority in her work is finding ways to implement obesity interventions that are accessible, non-stigmatizing, and effective. So Dr. Barlow, we have some questions here for you. Some of the questions are around this 26 hours for the intensive behavioral therapy. 26 hours over how long of a period of time, and do insurance providers cover these sessions? Those questions came in, and you kind of addressed it a little bit later in your talk after the questions came in, but I'll let you just respond to those again.
Yes, so great question. So yes, the 26 hours is over generally 3 to 12 months, because that's where the studies were done. And I'm sorry, the coverage, no, it is not covered. It should be covered, but it's not covered. But what's really exciting is that people like or organizations like the CDC are really working on that. So we're talking about finding some codes, especially codes that might allow coverage for programs that don't take place in healthcare settings, because that's the challenge, right? We're in offices that close down at 5:30 or 6, and aren't close to families. And we know that programs that might be delivered at a community center are much more accessible. And so we need to sort of bridge that gap between what works for the families in terms of location and time and what we can provide coverage for. So we're moving in that direction, but not there yet.
Great. And later during this summit today, we will be having a panel discussion with policymakers, legislators, facilitated through the Partnership for Healthy Texas. So hopefully we can address that a little bit more in detail in that discussion as well. We had a follow-up question. You've addressed part of it, but this person was asking about the 26 hours of intensive training, behavioral change training. Where does this get done? Is it in the home? Do families have to travel? What are the barriers that keep children from completing the 26 hours? So if you want to elaborate on that anymore, that would be great.
Yes. So that is the question here, right? We know that this approach works when it happens, but how do we actually implement it and get it adopted? So I think it's very hard for this to happen in a healthcare setting, again because the location is not necessarily close to families' homes. I think it can happen in community centers, YMCAs, that sort of thing. And I think we are really interested in rigorously examining whether some virtual or some component of virtual delivery could really, balance that, providing that time in a way that is really more possible for families and without interfering with school and work. Important research
that is one
that we need to do.
Yeah, that is one of the questions, was whether or not virtual visits count face-to-face. So there is some research in that area, but we need more to really understand the efficacy there. Is that correct?
Yeah, I mean, I think that we have telemedicine, which is sort of an individual visit with a healthcare provider, but we also know that group programs may be a more efficient, cost-effective way of delivering. And so can we do that through like a synchronous group visit? And Deanna and I are very interested in evaluating that. So
great. And I know in some of our work, the approach, the behavioral approach, really needs to vary by the stage of development that the child is in. And the involvement of the family will vary likewise. So adolescents are going to take a different approach than earlier childhood. I don't know if you want to elaborate on that at all, about the tailored approach for the age of the child and developmental stage.
Yeah, for sure. Probably the most work is in that elementary school age, 6 to 12, and for sure the family needs to be very involved with that. And in fact, I think programs that, and this can be hard when you're coming from a pediatric perspective, that address, the parent behavior for themselves as well as the parenting behavior for the child can be very effective. Adolescents, they do adolescents do like a little bit more independence. At the same time, there is a role for parents, and so it's maybe a little less removed. And then I think the preschool is a real challenge, because I think that is a fantastic opportunity for making small changes that have a long-term impact. But I think we struggle, in my view, with helping families recognize at that age that it is appropriate to jump in and make, we're not talking medications or surgery here, but really making important healthy changes to lifestyle, and not just waiting to see if the child outgrows it. So.
Great. Well, we have two other kind of distinct lines of questioning here. One is, first, some kudos. Thanks for the great talk. Are you aware of any reports on return on investment cost savings that would be helpful when talking with health plans?
So there's been some work in measuring the additional healthcare cost, predicting it over time, of childhood obesity. And I mean, to be honest, the cost doesn't seem that much, which is unfortunate. And I don't know if it's really accurate. So I can't remember. It's something like an additional $19,000 over a lifetime, which, you know, I suspect it's much, much higher than that. But that's where the data is. So I think what is important is to really look at finding low-cost ways of delivering programs, and looking at, you know, the sort of cost per child, and comparing that to some of the other medical costs that we have, which are, you know, are very high for even just evaluating some of the comorbidities. And I guess that would be the argument. But again, we need more data to go. And the CPGs, I think, will make, I hope, public and private healthcare insurances say, well, we have to think about how to implement, you know, how to support evidence-based care.
Okay. We have time for one more quick question here. If the child, adolescent, and family decide on bariatric surgery, how extensive is the psychological evaluation, or is that based on insurance criteria?
So a good high quality center will insist on the psychological evaluation. And, you know, for public insurance, which does, like Medicaid, it does cover bariatric surgery. That will definitely be part of it. I guess potentially for commercial insurance, if it's not well covered, it may be something the family needs to pay out of pocket for, which would be unfortunate, but, you know, it really is an essential part of the evaluation.
Okay. All right, great. Well, we are right at the end of the hour. We're going to transition into the next stage of our schedule. And I am going to turn the mic over to Dr. Emily Durander, my co-chair with Live Smart Texas, and Emily is going to facilitate.
Yes, thank you so much, Leah, and thank you, Dr. Sarah Barlow, for a fascinating presentation. I think, Dr. Barlow, you and the team with AAP have done a very challenging job of laying a foundation. And of course, there are always challenges, right, to meeting these new criteria and these new guidelines. And I just think you did a great job of kind of outlining a way forward. And thank you so much for your insightful presentation. So next, we are going to hear from our Live Smart Texas Steering Committee members. And some of them have offered to kind of give updates about what is happening around Texas, and particularly in their regions. And so first, we're going to hear from Dr. Martin Binks from Region 1. So Dr. Binks, you can go ahead and take it from here. Thanks.
Hey, good morning, everyone. Thank you all for having us here, and also thank you for Dr. Barlow. That's always a wonderful thing to hear your perspectives. So welcome from Region 1. I am located in Lubbock, and we basically serve the Amarillo, Lubbock, Plainview, Denver City, and all of the rural regions in between. I just want to start by saying I'm hoping that we'll be able to connect over the next year with more people in our region that are engaged in anything related to obesity. So if you know of anyone in the region or you are somebody, please just reach out to me directly and we'll make sure that we connect over the upcoming year. So I've been asked to give an update of what's going on in our region. So maybe we could go to the next slide. And this is one effort that's quite interesting. The Texas Tech University Health Sciences Center has a Center for Excellence in Integrative Health, and it is a broad umbrella. It brings together faculty, providers, students at all levels, including medical students and students from across the Texas Tech Health Sciences system, including the university side. They're really a collaborative hub for people. And if we could go to the next slide, this is most relevant. We have Dr. Shen leads the effort, and several, I guess 6 in total, including Dr. Shen, are focused in obesity in some way. And it's bench to bedside and beyond to community and public health would be the best way to describe the scope. And you know, some example, of course, there are research efforts, but all of these individuals, as part of our university mission, are engaged in community outreach and engagement. Some of our research engages with the community and so forth. So this reaches well into the community with good messages around obesity, especially from the clinical and community health folks. The one example of a great event recently, the mission to be able to reach the next generations of healthcare providers, we had an event where all of the very eager undergraduate honors type students came and heard various of us speak about careers in helping people with obesity and more broadly with health and wellness, and just seeing them engaged is great. I see that we've moved to the next slide, so I can talk about that one. The Obesity Research Institute is a virtual institute that brings together collaborative efforts also. And they have a number of engagement activities. Let's go to the next slide. Those are their leadership, Dr. Naima Mustad Musa, Janet DeFleur, and I'm sorry, I left off the name there and I'm blanking on it. We can go to the next slide. A few events. They're having their first event related to the celebration of women's health for Women's Day, and you can see the details there. It's coming up March 8th, and QR code, if we could go to the next slide. They're also they're doing their 8th annual meeting, which is a networking event that includes speakers and student poster presentations and so forth. And that's another highly engaging event. If we could go to the next slide. This particular effort is a way to engage, and I'm going to read this one to make sure I get it right. The program funds underrepresented students from South Plains College, Texas Tech, to engage in bench and community research focused on nutrition, agriculture, health, obesity prevention, all of which are high priority areas for rural West Texas. And they're really targeting the development, again, of people that will step in to serve our region and beyond. The next slide, please. This effort is our own effort here at the Nutrition Metabolic Health Initiative. And if we could just go to the next slide. That is our faculty that are engaged here, and all of these people are clinical researchers and clinicians who are reaching out into the community to help with bringing the messages around obesity. You've heard people first language, you've heard the idea of multidisciplinary treatment, and you know, every chance we get, we're in the community trying to bring that message across through various types of efforts we have. And if we could go, our overall mission is research, education, training, and community engagement in clinical care. And I'm going to highlight the last part, actually. We're basically doing research in community and metabolic diseases like obesity and metabolic diseases like diabetes and so forth, and overall obesity-related comorbidities, and we have clinical care targeting those. Next slide, please. That's just our location. We have a 10,000 square foot clinical research facility with lots of, you know, metabolic equipment and so forth. If we could go to the next slide. That is the breadth of our work in obesity, nutrition, and metabolic diseases, and including the metabolic testing, clinical weight management programs of all different types, also healthy nutrition, physical activity counseling, and health coaching, and so forth. This effort serves community members through programs to the community, and also in our outreach efforts to engage the local community in understanding obesity better. Checking the time, we're still got a minute or two, so let's go to that next slide. Highlighting our community outreach and engagement events. So we have pretty much just ask and we'll come speak, and we publicize that on our website and on television appearances and so forth. We just never say no to engaging our community. Community events and health fairs are part of our mission. We do open houses and health screenings. Last year for World Obesity Day, we did one of these and have done them for other events. We are collaborating with the local medical center and with Texas Tech University on providing employee wellness, and recently worked with the rural communities towards Midland, Odessa area for the Rural Health Initiative to help provide some skills to them. Of course, research, and then we have undergraduate, graduate student training programs. We have a high school experience that brings high school students in to play with all of our equipment, learn about obesity and nutrition, and we've recently developed an internship collaboration with Princeton University. That brings me to the 9-minute mark, so let's just say thank you very much, and please reach out if we can be of assistance in helping you engage with obesity.
All right. Thank you so much, Martin, for all the information about what's happening in your region. And next up, we have Kara Hanalkoa to tell us what's going on in Health Service Region 7.
Hi, good afternoon, or good morning. Time is flying. I'm Kara Pryor-Hanalkoa, and I am the Vice President of It's Time Texas, and representing Region 7 today. So as you can see from the little graphic, Region 7 covers the area of Travis, Bell, Brazos, Hayes, Milam, McLennan, Williamson counties. So this region is commonly referred to that Central Texas region. And before I share more about Region 7 specifically, I wanted to share briefly about It's Time Texas as a resource in Region 7 and across the state. It's Time Texas's mission is to save lives by reducing the incidence of preventable diseases while increasing access to health for all Texans. We are working towards the vision that every Texan has equitable access to a long and happy, healthy life. Awesome. I saw a little thing appear. So before heading into the specific updates, I want to first acknowledge and celebrate that there is an extensive variety of obesity prevention efforts happening across Region 7, supported by public health departments, academic institutions, nonprofits, and healthcare institutions, just to name a few. These groups have created nutrition education and physical activity interventions that meet community needs and empower community members to improve their health, Just examples of this in Region 7. You'll hear about a few of these initiatives today, including the Community Challenge, and I think a little bit later you'll hear about Walk Across Texas. So all of those things are happening here in Region 7, and I just want to acknowledge and celebrate that. There's also comprehensive and community-informed research taking place throughout Region 7 on obesity prevention efforts and social determinants of health that impact communities. This includes things like working with city governments on evaluating equitable access and funding to parks so that community members have that environment needed to succeed at living that long and happy, healthy life. And here in Region 7, we're so lucky to have institutions like the Michael and Susan Dell Center for Healthy Living, which is behind this event, and that's located here in Austin, and groups like Baylor Collaborative on Hunger and Poverty, and other academic institutions. So I want to acknowledge all the great work that's happening here in Region 7. And to Martin's comment, if you are a group that is active here in Region 7 in one of those counties I mentioned, feel free to reach out to me, Kara at It's Time Texas, Kara with a K, .org, and I'd love to connect with you. So with that said, I'd like to share some specific upcoming opportunities, as I know we have many public health professionals and community advocates here on the summit today to engage in the conversation around obesity prevention. The first is the It's Time Texas Community Challenge that it is wrapping up this week. There are only a few more days. It will end March 5th. This is an 8-week obesity prevention intervention that encourages individuals to increase physical activity, water consumption, and fruit and vegetable intake. So if you haven't participated, there's still time. Go on to itstimetexas.org, register. This may be a community intervention that you might want to share in your community, and it is an annual competition. It's Time Texas will also be celebrating communities that had the highest level of participation in the next few months to promote awareness of obesity prevention efforts and recognize these communities, their civic leaders, all of their champions for their commitment to healthy living. So you'll be seeing more about that, and I can tell you from the scores currently, there will be a few Region 7 winners. And so very excited to announce those soon. Some other opportunities coming up is another group that's a part of Live Smart Texas is Texas Action for Healthy Kids. We will be co-hosting a School Health Advisory Council workshop on building parent engagement. So many of you know that school health advisory councils are essential to addressing childhood obesity in our schools. They're really this collaboration between school administrators and parents to help make schools as healthy as possible. And this workshop will deliver techniques to increase parent engagement in school health advisory councils. It's a big barrier. We know we want our parents involved, and that is really the way that we're going to make an impact in children's lives. I also want to share a series of upcoming conferences happening in Region 7. We like to learn in Region 7. We love to have some conferences. And so these are opportunities to collaborate with like-minded individuals and organizations to discuss obesity prevention efforts. So one that's coming up that is a little bit more on the policy side is the Texas State of Reform Health Policy Conference. It is happening in 8 days on March 9th. And so this conference is specifically focused on Texas healthcare policies. And there is a great breakout session focused on health equity and community health and the intersectionality between that and policy. So check that out if you can. The next two are interconnected. They kind of bounce off of each other, and that is the National Summit for Health Communication and the University of Texas Health Communication Leadership Institute. I've heard great things about these. These will both be in Austin in June, the 12th, the 13th, 14th through 16th. Both of these opportunities are specifically on health communication and will strengthen skills in things like data storytelling, public health awareness campaigns, and more. So if you're in the obesity prevention, health communication sector, this might be something you want to explore. And finally, I'm so excited to announce that October 5th and 6th, It's Time Texas and the University of Texas system will again be partnering on the 2023 Healthier Texas Summit in Austin. This two-day public health summit will convene Texas thought leaders and health champions to connect and increase access to health through cross-sector partnerships and allow attendees to gain skills to implement policy, systems, and environmental changes in their communities to advance health equity. Obesity prevention is always a very specific topic that we address during the summit, and I'm really excited to see a lot of you there this year. So if you have any questions, I'm happy to answer them at the end, and thank you all so much for your support.
Thank you so much, Kara, for the update from Health Service Region 7. And next we have updates from Health Service Region 8 from Denise Benoit Moctezuma. Thank you.
Thank you for having me. It's great to be joining you on this day that we're launching the National Nutrition Month. And I just want to say thanks for having us. I'm going to be focusing more on San Antonio and some of the things going on here in the city and around Bexar County. I am the Region 8 rep for Live Smart Texas, and I work with Metro Health. Before delving into our initiatives that are about physical activity and nutrition, I will be highlighting the socioeconomic and health disparities here in San Antonio. This is a snapshot of the issues we're experiencing and what we've learned by reviewing the data and really thinking about social determinants of health and how we can use that information to develop more comprehensive programming. Really thinking about upstream interventions that reduce downstream health effects or complications. This slide shows the poverty level here in San Antonio. 17.8% of people live below poverty in San Antonio, which is higher than the state level at 14.7%. The children in poverty is 21.6%, which is higher than the state at 20.9%. Next slide. More than 250,000 Bexar County residents have a hard time finding food to eat on a daily basis. 14.7% of households in San Antonio depend on food stamps or SNAP benefits, and about 20% of our children are food insecure in San Antonio. Next slide. You can see here that our health informatics team at Metro Health has helped us to develop some maps showing where the highest rates of diabetes, obesity, and hospitalizations due to diabetes are occurring. As you can see on the left, the map shows that these are the percent of adults with obesity, and we have they have included a city council overlay showing exactly which districts we need to be looking at which have the highest rates of obesity. The map on the right shows the highest rates of diabetes, and you can see that these two maps look very similar. So we're seeing the highest cases and rates of diabetes and obesity on the west side, the east side, and the south side. Next slide. Here you can see that the diabetes hospitalization rates look very similar to the diabetes and the obesity rates in the city. Here you can see also that the highest rates of diabetes hospitalizations occur on the west side, the east side, and the south side as well. What are these maps telling us? They are telling us how we should be thinking about and where to be localizing our efforts to really show and get some impact that will be downstream or down the line to see more health impact and really reduce health disparities. Next slide. Our health department has been engaged in strategic planning over the last few years, and we've identified 6 health priorities that we're focusing on over the next 5 years. This plan is called the SA Forward. Next slide. We've identified the 6 priority areas here: access to care, data and technology infrastructure, food insecurity and nutrition, health equity and social justice, mental health and community resilience, and violence prevention. I'm going to be talking about the food insecurity and nutrition focus area. Next slide. Here you can see that we have initiatives in this area that focus and really think about addressing food insecurity by increasing access to healthy foods and collaborating with partners to make systemic changes. The initiatives that I'm going to highlight today are to expand our Viva Health and Por Vida using a community health worker model, establish a food insecurity work group, expand peer-led diabetes prevention and control program, adopt Healthy Neighborhoods program expansion, and expand our Healthy Corner Store program. Next slide. First, I'm going to talk about expanding our Viva Health and Por Vida using a community health worker model. Viva Health is a nutrition education campaign for San Antonio that motivates and promotes healthy eating patterns for individuals and families. Por Vida is a healthy restaurant recognition program that encourages restaurants to offer healthier menu options. I have provided the websites below so that you can go and see and get more information about these programs. Next slide. Our Viva Health program works with community health workers to train and or provide technical assistance to 12 new partners a year, thinking about the South, East, and West regions of San Antonio on culturally relevant Viva Health nutrition and education. The goal for the next 5 years is to work with 48 new partners in those regions that we need to be providing more local effort and increase our access. Por Vida works with community health workers to recruit 12 local Por Vida restaurants per year that serve healthier menu options in areas that have lowest access to healthy foods. And we also have a goal of working with 48 new partners over the next 5 years. Here on the map to the right, you can see that the majority of the Por Vida and Viva Health partners have been in the central part of the city. Now we're focusing our efforts to really think about these health disparities on the west side, east side, and south sides. So that'll be D2, D3, D4, and D5 areas. Next slide. We also will be establishing a food insecurity work group. We do have a team working on this from our new program or a new office called Policy and Civic Engagement. That team is actually trying to develop the food insecurity work group with at least 10 internal and external partners. And they will be hoping to influence 4 policies that lead to a more robust local food system and or reduce food insecurity. Really, this particular group is also working to implement a food insecurity assessment that will help this food insecurity work group down the line. Really thinking about these 3 areas of food for today, feeding the line, with increasing food pantries, farmers markets, and community gardens in different areas of the city, and food for tomorrow, really thinking about enrolling more people into SNAP, WIC, and really changing some policies to help people access more food. And then food for a lifetime, really thinking about social determinants of health and how we can help and empower people to get out of poverty. Next slide. We also will be establishing and expanding more of our effort into those areas that we mentioned on the west, east, and south sides. So we're expanding our peer-led diabetes prevention and control program, really thinking about offering workshops in the districts that have the highest rates of diabetes and hospitalization rates due to diabetes complications, using our Prevent T2, Deep Diabetes Garage, and Viva Health workshops in these areas. We're also partnering with district offices to identify workshop hosts and participants, partnering with neighborhood associations, and have developed some specific resource guides to promote more physical activity and healthy eating in these districts. The next slide shows the example that we have. Next slide, yes. With our district guide for our District 2 area that has our Por Vida, Healthy Corner Stores, our Diabetes Prevention and Control Contact, our WIC contacts, and the free or no cost fitness classes that Parks and Recs also provide in these particular areas. So we have a district guide for every district in our city, and they are in English and Spanish on our website, and we'd be happy to link you to those. If you would like to reach out to me, I can show you and connect you to where those are. Next slide. We also have some initiatives to expand our Healthy Neighborhoods program and to expand our Healthy Corner Store program. Our Healthy Neighborhood program is a community health worker program where they reach out to the highest needs areas of the city, specifically working in neighborhoods to provide nutrition education, physical activity, and cooking demos, and so much more. Currently, they are working in 15 neighborhoods across the city. And they also are the group that has actually initiated the Healthy Corner Store program, where they are currently working, as you can see the map on the right, with 34 locations currently. Their goal is to expand the program to 50 locations by the end of the 5-year period. Next slide. We also have a team, the newest team of our community nutrition program called the Nutrition Policy Team, and they are working very closely with our Healthy Neighborhoods team and our Civic Policy and Civic Engagement program, our office, to shift the focus from obesity to nutrition diversity, equity and inclusion, and using body positive and body inclusive language. For more information about that, please contact me so I can connect you to the group that's working on this particular initiative. Next slide. And finally, we have our Mayor's Fitness Council, who is currently supporting the Student Ambassador and Student Mentor program that we have with middle school and high school students that actually plan and implement student health service projects in their area, in their community, and at their schools that really centralize their projects around nutrition, healthy eating, physical activity, and mental health. Mayor's Fitness Council also has supported It's Time Texas Community Challenge, where San Antonio has been the Metro City champion for the past 7 years, and the mayor is very excited about that and continues to support this effort as well. Mayor's Fitness Council also supports the It's Time Texas Move Your Way campaign, with local efforts occurring here in the city and across the area, where we really focus on encouraging and promoting no-cost physical activity opportunities and easily accessible areas to engage in opportunities for physical activity, and are developing new ideas and new efforts, events, such as our Greenway Trail event that we're planning for the fall. If you'd like more information about the Mayor's Fitness Council, you can contact us at fitcitysa.com, and you can see all the information I just mentioned, along with videos and podcasts about the Mayor's Fitness Council and other things going on. Next slide. We'd like to thank our community partners and just wanted to say thank you. We cannot do this work alone. And if you need to reach me, next slide, you can see my email there, and please feel free to reach out to me to connect and to find who you can contact for these initiatives. Thank you.
Thank you so much, Denise, for the update from Health Service Region 8. And next we get to hear from Dr. Leah Whigham, my fellow co-chair, who is also telling us about what's happening in Region 9 and 10.
Excellent. Thank you, Emily. So our regional rep for Live Smart Texas for the 910 region is Pema Garcia, but she couldn't be with us today. She's busy running some programming in the community today and this weekend in celebration in honor of World Obesity Day and Obesity Care Week. So I told her I would gladly cover the presentation today. Next slide, please. Region 910 is located in far west Texas, and what I did for this presentation today was I reached out to our partners throughout the region and asked them to send me slides. So you will actually see slides directly from our community partners and some slides that I've curated myself. So our research center, the Center for Community Health Impact at UT Health Houston School of Public Health El Paso campus, works to coordinate and partner with organizations throughout the region to address obesity on a population level. You can see some of our community-based activities here, including convenings and projects where we work with evaluation with our community partners so that we understand which approaches are driving the greatest impact. And then we have some community events like the ones you see in the bottom left corner through our partner La Semilla, talking about their edible education program. Next slide, please. The approach we use is based on two models, one, the collective impact model, and the socioecological model that drive our strategy around addressing obesity at a population level. We use a very community-driven, science-informed approach. So as scientists, we would not be able to drive change within the community if we didn't have good partners who are actually implementing the programs and the projects and the policy changes that make that impact possible. So what we try and do is provide support for them, and that partnership is essential to what we do. We have 5 main partnership areas: food systems, obesity management in primary care settings, the built environment, workplace wellness, and healthy schools. And we have these 3 functional cores that you see on the left side of the screen, and those allow us to really drive forward this mission of community-driven, science-informed change that addresses obesity at a community and population level. So through our implementation and evaluation core, we help those community partners collect data on the impact of their projects. When needed, we can provide technical assistance and capacity building as well, but we're really there lockstep with those partners to help them strengthen the projects that they're doing. And I'm going to describe some of those programs here in a moment. We're also working hand in hand with those partners to identify where the gaps are. What do they need to be able to do what they do in a more effective and efficient way? And some of that requires us to build new tools or adapt approaches and test them out. Sometimes we need to test them out in a lab or clinic environment, sometimes right in the community. So we have a translational research core that facilitates doing that. And then we have our policy and advocacy core, because as you heard when Dr. Barlow spoke, for example, earlier today, oftentimes there are policies in place that limit the effectiveness that our community partners can drive with their programs. And to address that, we need to make policy changes. They can be at the school level, at the workplace level, at the state level, at the national level. And so we're proud to work with regional, state, and national partners to drive policy change and advocate for those changes. Next slide, please. And as part of our work, we are now opening the El Paso Nutrition and Healthy Weight Clinic. That will be part of our translational research core, where we will partner with El Paso providers and patients for better health. Next slide, please. So I'm going to talk about some different projects. As I said, most of these slides were sent in by our community partners, and that approach, that collective impact approach I spoke about, includes all of these partners that you're going to see slides about their programs today. So La Semilla is one of our amazing regional partners. They work in southern New Mexico and West Texas, cultivating health through foodways, education in schools, and community spaces. So they have this intersection of community education with community-based gardens and engagement, edible education, which is school-based gardens, and they use a lot of storytelling and facilitate a farm fresh program, as well as a community farm. So they're really working to integrate all these components to help strengthen our local and regional food system. And they are great partners. We're working closely with them right now on several projects. They have funding from the USDA through the GusNIP mechanism to implement a vegetable prescription program with partnering with local healthcare centers. As I mentioned, they've got their edible education program in place. They're really doing a lot of great work. Next slide, please. Common Threads is a national nonprofit that provides children and families cooking and nutrition education to encourage healthy habits that contribute to wellness. They have programming happening throughout the state of Texas as well as nationally. I'm proud that they were able to get established in our region through a grant proposal effort that we partnered with them on probably about 8 years ago. So it's great to see that they're still in our community, leading multiple types of programs and really help drive collective impact forward when it comes to nutrition. Next slide, please. Some of their programs include a teacher-led Small Bites program for pre-K through 8th grade, cooking skills and world cuisine, which targets 3rd through 8th grade students, family cooking classes, which is a series of 2 2-hour lessons that engage caregivers, students, and extended family members. Ask a Chef. These are cooking demonstrations geared towards family participation, and the parent workshops. And these programs engage parents and encourage healthy eating habits at home. They've also partnered in our in-store Coalition, which is a coalition that delivers programming in grocery stores, and they work with our coalition of in-store program deliverers who do some grocery store tours right there in the grocery store, helping people learn how to navigate the grocery store and purchase healthier foods on a tight budget. Next slide, please. Youth on the Move is a program being developed at New Mexico State University. This is a physical education teaching method that addresses each individual student and helps address sedentary behavior. The PE teachers in El Paso and southern New Mexico are using this method, and NMSU is writing an online class for teachers in Texas, New Mexico, and elsewhere who want to learn to use this method. Next slide, please. Also coming out of New Mexico State University, Continental Cooking, which addresses the lack of nutrition instruction for teens. And through this program, teens learn how to grow produce, use produce they grow to make meals for their families, and advocate in their families for healthier eating habits. Those of us who are parents know how much it helps when the teens in the household are the ones driving the change. So the program launched in fall of 2022 and continues this spring with recipes from 6 continents. Next slide, please. Sabrosa Vida is a cooking program that we helped to revamp. This program was originally commissioned by the Paso del Norte Health Foundation, which is a foundation that funds a lot of health promotion and disease prevention work in our region. We are lucky to have them as partners and leaders in our region. And the Sabrosa Vida program that was originally developed over a decade ago, we worked with the Paso del Norte Health Foundation to revamp that program. And now it's being delivered by El Paso Center for Diabetes. And the Sabrosa Vida program is designed to really drive forward enjoying cooking and the flexibility within the kitchen to adapt recipes to meet the taste preferences of families. While we care about nutrition, if all we teach is the nutrition without recognition that food is part of our culture and the taste and enjoyment of food is important, we can kind of miss the opportunity to engage a lot of key target audiences. Next slide, please. And so Sabrosa Vida, each class consists of class objectives, a brief nutrition lesson, and a cooking demonstration led by a chef. And they review food labels, use SMART goals established for each model, and do taste testing of the prepared food. There are 5 modules, and you can see the modules there on the slide. So they start off with an introduction to cooking that includes cooking skills and knife skills, and talk about carbohydrates. In the next session, they learn about vegetables, then proteins. They learn how to enjoy desserts with bite-sized desserts. So how do you control the portion in order to still enjoy desserts and have fun with food, but not overdo it when it comes to the health impact of the food? And then there's been a big interest in international cuisine. So the chef, Dr. Sarah Ruiz, who has done a lot of the program development for Sabrosa Vida, has really done a great job bringing in international cuisine recipes. Next slide, please. Another partner in the region is Kelly Memorial Food Pantry, and Kelly Memorial has done a great job of providing food to people with food insecurity over the years. About 10 years ago, when I first toured the food pantry, the director said to me, "But Leah, it's just not enough. We won't be happy until people don't need to come back to the food pantry." And so they were doing a very traditional food pantry distribution, boxing up food and distributing to people coming to the pantry. But they wanted to do more, and seeing that drive to do more reminded me of a researcher from Connecticut I met who had done some research in this area. And her name is Katie Martin. She's shown there on the slide, and she was doing some really innovative programming in food pantry settings and actually completed a randomized controlled trial specifically to look at how to drive greater impact and address the root causes of food insecurity. Next slide, please. So we connected with Katie. You can see her here in El Paso in the early days with the Kelly Memorial Food Pantry team. And we brought her program called Fresh Place to El Paso. And Kelly Memorial Food Pantry now runs that program called Fresh Start. And this program addresses the root causes of hunger through case management, where each participant gets to work with a case manager to set their own goals. And then they progress through the program over 9 months with access to nutrition education, learning how to shop for healthier foods without spending more money. And importantly, the pantry has shifted to a choice model where pantry members can come into the pantry and choose the foods that work well for their family. Next slide, please. Through our evaluation, we showed that nutrition increased in participants, as did food security improved. And so you're seeing some images here from some graduation celebrations of participants in the program. And this program continues today. So not only is it effective, but it has been sustainable. Next slide, please. And Desert Spoon Food Hub is a food hub working in our region to connect growers to consumers. And they developed this very innovative program called Taster Space, which has been implemented over the last 2 years now. And in this program, they started to roll out this program just as the pandemic hit. So the fact that Desert Spoon had the capacity to do home deliveries of local produce turned out to be a really valuable asset for this particular program. What they do is they deliver a box of produce to the families, to the homes of the families participating in the program, and the program targets children in the household. So the box shows up with fruits and vegetables, and you can see on the bottom left side, there's a brochure that's included that shows some activities and recipes that the kids can make with the particular food that's in the box that week. There's other tools in the box like table talk cards that give parents some ideas of things they can talk to their kids about over the dinner table. And the kids track through an Explorer log what they like about the fruits and vegetables that they're tasting. So the goal is really to get them to taste new foods, try new fruits and vegetables, play with the food, explore the food, and they use this space theme, including Astro Billy, who you can see there, who shows up in costume for various events that they do with the children. So another really positive program focusing on getting kids exposed to more fruits and vegetables and increasing the liking of fruits and vegetables. All right, next slide. I think that's it. And that's our update for Region 910. Thank you.
Thank you, Leah, for the update. And now we have our last update from the Live Smart Texas Steering Committee. Mike Lopez, he's a representative from Texas AgriLife Extension. Thanks, Mike.
Yeah, can you hear me okay? Just to confirm before.
Yes, absolutely.
Okay, awesome. Thank you so much for the introduction. I'm really excited to be here and representing Texas A&M AgriLife Extension, as well as Live Smart Texas. I'm the organizational representative for Texas A&M AgriLife Extension. So my role within AgriLife is I'm an extension program specialist in our Family and Community Health Unit. I mainly focus around programmatic efforts related to our team-based physical activity programs, which is actually going to be the emphasis of the overview that I'm going to be doing. But then I also help support communities across the state with a focus on policy, systems, and environmental change for behavior change and specifically planning for active communities. So what are some of the environmental influences on behavior, specifically physical activity, and how might we be able to promote that behavior change? And so if we could go to the next slide, please. Just a little bit of background, just in case you haven't heard of Texas A&M AgriLife Extension before. Texas A&M AgriLife Extension is one of the land-grant institutions in Texas. Our mission statement provides the purpose of AgriLife Extension and mandate for the vast network of professional educators that serve each of the 254 Texas counties. There are different disciplines and program areas represented that address and serve the needs of Texas, but the overall goal is to change human behavior. Family and community health, which is where I'm based out of, our family and community health unit, our program efforts specifically address physical activity and active living in support of chronic disease prevention efforts. And we do have a variety of other program disciplines within our family and community health unit as well. If we could go to the next slide, please. So what I'm going to talk about in terms of our organizational update is some of our efforts related to our centralized website and database for some of our family and community health program efforts. And so the terminology that we have for this system is Howdy Health, which the link is at the bottom of the screen as well if you'd like to visit howdyhealth.tamu.edu. But what this slide is highlighting is it's highlighting kind of the not only the process that we took in the development, but also what we hope to achieve with this website. And so you could see the numerical going through the numbers right there. Starting at the top left is our Howdy Health website, and this is open to the public portion of the website that has a variety of different information. And part of the aspects of the front end of the Howdy Health website is around educational content, because that's one of our big efforts within family and community health and within AgriLife Extension is promoting behavior change through educational efforts. And so we do have a variety of educational content under a menu item that we call sync articles. And so if you're visiting the website, you could find those there. We also have a pretty robust help desk ticket system due to some of the programs that are implemented through the Howdy Health website. So we have that on the top left here, and then we also have what basically houses the website. To break it down for a 10-minute conversation is we do have a centralized server and database. The database is mainly around our program developments, since each program has its own unique database, because not only is this a front-end website where there's educational content and there's information that we have to share from family and community health, but also the website is where a person goes to implement or engage with our online programs. And so the database is the backbone of that for each unique program. And so if we break down, some of the services that are comprised in the centralized website, is that we have, starting on the left there in the user interface, so we do have a complete web responsive user interface. And so what that web responsive means is that everything is tailored to whatever device that a participant might be using. And so we do have, so it doesn't serve as a native app like you would download from an app store. However, it is functional as a website within your phone, within your tablets, within your laptops, within your desktops, etc. And so the user interface is where people go to and participate in the programs, which I will describe the current physical activity program offerings that we have in the next slide. But before we get to there, we have that user interface where that program implementation is occurring, completely mobile and web responsive. And then we also have an internal program system where our extension staff, there are a variety of programs that, given that we have some programs that are online, we may have other programs that to meet the needs of all Texans that may not interact with an online website or system in order to participate in that program. And so we do have a variety of in-person program efforts that our extension staff and our professional staff across the state implement. And so we do have a large, robust internal program system where it houses resources for our staff. It also houses some of our program assessment pieces, as well as some data entry for tracking and monitoring of some of those program efforts that occur face-to-face. And so we do have that system as well. And then we also have a large report system, because part of our, which I'll end with describing some of the outcomes in this some of our selected program outcomes from some of our physical activity programs. But we also, our internal extension staff has a robust internal report system for not only helping support their promotion, recruitment, and engagement for some of the programs that we offer, but also to look at their outcomes at the end of the program. So if we could go to the next slide, please. What I'm going to do is I'm going to talk about some of our current physical activity program offerings. And this time I'm going to start on the right side. I'm going to start on the right side with our 10,000 Change program. That is an individual adult-based program that essentially steps or progresses an individual through a variety of different stages to hopefully at the end of the program achieve 10 servings of fruit and vegetables and 10,000 steps. And so it does take a stepwise pattern, and it does have a theoretical framework to promote behavior change that's embedded in that program design, where a person registers, tracks and monitors participation in the program during it, and then has a closeout post-program assessment piece as well. If you do have any motivation, or if you'd like to learn a little bit more about that, I highly encourage you to visit that howdyhealth.tamu website. I don't provide direct support for that program, but I just wanted to introduce it as one of our current physical activity program offerings. And then next, moving towards the middle of the slide, we see our one of our youth focus program, and that's our Walk Across Texas youth program. And so that program is tailored for a youth audience. It is an 8-week program that's essentially a virtual journey across Texas. And so youth teams are logging miles across the 8 weeks of the program to see if they could virtually walk across the state of Texas. And then in the far left now of the slide, we see our adult-based programs, adult team-based physical activity programs, our Walk Across Texas adult program, and our Walk Through Texas history program. So those are what's available right now. If we could go to the next slide, please, for me. So each of these program designs do have a theoretical framework embedded into the website and the tracking and monitoring aspects of the program website. And so the theoretical framework behind these programs is the social cognitive theory. In a 10-minute overview, don't have a whole bunch of time to go over everything, but I will make note that some of the concepts or constructs that you may be familiar with as part of the social cognitive theory, there are a variety of different strategies that our professional staff as well as the website incorporates into their program efforts. And so you can see at the bottom where the little stars are, the little asterisks, where which of these concepts or constructs that within this theoretical framework are leader-led, which that could be from one of our professional staff or one of our program partners who are implementing the program. So for example, if there are any events or activities to help enhance or make the program extra special, that might fit with there. The 2 stars are something that's participant-led. So that is something that's embedded into the program design. That's something that the participant takes ownership over. So for example, under self-efficacy, we could see the tracking and monitoring of mileage. That is something that is directed by that participant who is engaging in the program. Then the third one, the 3rd star is the embedded into the program design. And so that is the individual and team goals that I got ahead of myself there. That is each of our team-based physical activity programs have a unique goal. For example, the Walk Across Texas program is the overall program goal is to virtually walk across the state of Texas, which is 832 miles as the crow flies, in case you were wondering. And then our Walk Through Texas history program has a variety of different historical routes that a team is going on a virtual journey through. So if we could go to the next slide for me. So that's the theoretical framework for it. Just to talk about some of our selected outcomes, because this was the idea was to provide an update of our previous year efforts. And so I do have some selected program stats. We are about to publish our year-end brief, which will be publicly available on Howdy Health on the Howdy Health website very soon. But y'all are getting a snapshot of the insight first. On our left side here, we'll see the Walk Across Texas program. I think what I'll highlight is with that program, we reached an audience of a little over 37,000 program participants with over 2.5 million miles logged. for the year. We also reached 133 Texas counties, which is absolutely phenomenal to reach over 50% of our Texas counties there. So we're very excited about that. But we're also very excited about the effectiveness of the program. And you can see on the selected program outcomes, you can see the average, some of our selected outcomes. What I think I'll just highlight in the time that we have is that participants meeting physical activity recommendations, we saw an increase of 16% pre to post of those that self-reported meeting physical activity recommendations. So very excited about that, but then also reducing physical inactivity, seeing a decrease of 12%. So that is negative is actually, you know, a positive for our selective outcome, because those that self-reported no physical activity prior, that at 20% reducing to 8%. Then Walk Through Texas History has similar program outcomes there. So we're really excited about the effectiveness of that program. If I could just go to the last slide for the last, I think, 30 seconds that I have, are just highlighting some of the program testimonials from our participants. So if I could get to the next slide real quick. All right, and now we'll just leave y'all with, looks like the template didn't go through, so looks like there might be a missing bullet point there, but I'll just leave y'all with being able to glance through some of the selected program quotes and testimonials that fit within our theoretical framework. We're talking about the tracking and monitoring, keeping track, the team-based approach which keeps people accountable, and then also, you know, having fun, self-efficacy, confidence, getting healthier is another important thing that we're really excited about. And so I will leave with that. That was a very quick snapshot. If you have any questions, feel free to reach out.
Awesome. Thank you so much, Mike. And that concludes our updates from the Live Start Texas Committee. And hopefully you can see that there's a lot of effort going on around the state to reduce obesity, and certainly a lot of energy and a lot of enthusiasm. And thank you so much to everyone who presented today. So next, I'm going to hand it over back to Leah so that she can introduce our panelists from the Partnership for Healthier Texas.
Excellent. Thanks so much, Emily, and thanks to all of our flash presentation presenters. Well, I'm happy to be able to introduce my colleague, Joel Romo. I've been fortunate to work with and learn a lot from Joel over the last several years as I've gotten more involved with Partnership for Healthy Texas. So this next segment of our summit will feature a panel which will be moderated by Joel, and I'm going to hand it over to him now. Joel, to you.
Well, hello, and thanks everybody for being here. Thank you for allowing the Partnership for Healthy Texas to be part of this today, the World Obesity Day. We're excited and we appreciate all the work all our partners take on in terms of advancing the mission of preventing obesity and addressing chronic disease issues. On behalf of the Cooper Institute, we are excited to be part of Partnership for Healthy Texas in our World Obesity Summit today. I do want to give folks an idea of what we expect to accomplish over the next hour. As on behalf of the Legislative Committee of the Partnership for Healthy Texas, we'll be providing an introduction into the partnership's legislative priorities for the current 88th session, as well as where we are with the rest of the session and what's going on. Then we'll have a panel of experts working on policies this year that are addressing obesity that will join us. So right now, what I'd like to do is make sure everybody can see my PowerPoint here. Let's see, is everybody able to see? There we go. Is everybody able to see my PowerPoint?
That looks great.
Okay. Let me get to where I can advance it. Apologies. So just having a little technical difficulty on my end here. Okay. So the mission of the partnership is to develop approach set policies to prevent and address obesity in Texas. Let me go back a little bit. we organized in 2005, all these different organizations came together to focus on the mission of preventing obesity and policies that address obesity at the state legislature. We decided it was better to work together versus in individual capsules. So we brought all our resources together. In our first session, had 6 priorities, 5 of which became law, and 1 we went through the Department of Agriculture, and we were successful in advancing all those. And so we, since then, have continued to work together to advance policies, identify policy priorities. We have partner coalitions, Live Smart Texas and the Texas Public Health Coalition. We also are fortunate to have educational resources from our friends at the Michael and Susan Dell Center for Healthy Living and the MD Anderson Center. As I mentioned, we came together in 2006. We bring together a wide array of coalition experts, stakeholders, advocates that are all committed to addressing obesity through evidence-based policies. We are the only statewide policy coalition dedicated to ending obesity in Texas. Some of our historical accomplishments have been passing, of course, legislation to require minimum minutes of physical activity, and also which established the requirement for physical fitness assessment tests in schools known as FitnessGram. We have supported the passage of evidence-based obesity initiatives at the Department of State Health Services. We passed some legislation to update minimum child care standards related to nutrition, screen time, and physical activity. And we continue to work on legislation to streamline the application for SNAP for senior citizens and address hunger among our senior citizens. For the 88th session, we spent the last year prior to working with all our partners to identify what our priorities were going to look like for this session. Also looking at the legislative landscape to identify those priorities that we felt we could advance collectively. And so I'm going to just touch on some of those real quick. The first one is modernizing Texas SNAP to eliminate food insecurity and allow access to healthy foods and decrease the risk of obesity. We are looking at an update to the SNAP Vehicle Asset Test Program that to help adjust some of those limits. We're also looking to address hunger on community college campuses by allowing those students in those vocational technical programs to access those benefits. We have definitely see a need for that. And we're, of course, advocating for funding to implement SNAP incentives program and double up food bucks. We also are going to be playing some defense. Every session, there's efforts to either eliminate requirements or minimize the number of minutes of PE, etc. So we haven't seen bills filed on this yet, but we are looking to make sure we preserve and protect the requirements we have in regards to PE, what's existing in health, as well as the fitness assessments. We also want to make sure that we invest in healthy schools by allowing local education agencies to draw down federal funds from Medicaid services provided to Medicaid enrolled students. And of course, identifying different transportation policies through safe routes to schools that our partners are making sure that we have in place, but also preserve what we have. In terms of the other policy area we're looking this session to work on is empowering Texas Medicaid to implement initiatives that include evidence-based treatment for healthy food interventions. This would include evidence-based weight management therapies as benefits for Medicaid, and the adoption of a statewide policy framework to better integrate clinical and community services to improve access to healthy foods. And so with that, those are our priorities. We meet weekly at the Capitol as a legislative committee, and we feel free to sign up to the partnership for healthytexas.org to get updates. But I'd like to go ahead and move forward and introduce our panel of our policy experts that are working currently on policies related to obesity this session. And then, of course, we want to remind all our participants that you can ask questions for the panelists in the chat box. With that, so I'm going to introduce our panelists in the order that they'll be presenting today. And we have Lindsay Lanigan, Vice President, Government Relations and Public Affairs for Legacy Community Health. Rachel Naylor, the Executive Director of the Texas Association of Health, Physical Education, Recreation, and Dance. Of course, Dr. Leah Whigham, the Associate Professor at the University of Texas Health Science Center School of Public Health. Thank you for joining us, and we look forward to let each panelist introduce themselves and give a brief introduction to the policies that you're currently working on.
Hi, everyone. I'll start off. Since I was the first one mentioned. My name is Leah again. I work for Legacy Community Health. Legacy is the largest work with individuals outside of the four walls of the exam room to really address not only, their health care, but also all of the things that contribute to someone's health care. And so food insecurity has been one of the biggest issues that we've worked on over the last 10 years. And so the bill that I'm working on right now is really to address some sort of reimbursement for working with food banks or community organizations that provide food in coordination with a medical provider. And so we're looking at the Food RX program as well as medically tailored meals. We launched a study with UT Health and with the Rockefeller Fund with a pretty significant amount of individuals that are enrolled in the program and seen some amazing outcomes when it comes to the body mass index, as well as AO1C3s, and as well as really looking at gestational diabetes in pregnant women. So happy to talk a little bit more about that legislation, but I'll just briefly introduce myself and say hi. So thanks, y'all.
Hi, I'm Rachel Naylor, and I will go next. We are working on protecting our current physical education requirements that we have in the state law. Also, we would really like to see health come back as a graduation requirement at the state level. The other pieces that we are working with is also the importance of physical fitness assessment, and really overall just putting health and physical activity in the forefront of being an importance. Even though they are not tested and they are not considered as having a measure of accountability that hits at the state level, other than FitnessGram, it is important that we remember that preventative health and educating our youth is a good way to conquer and beat obesity.
Thank you, Rachel. Dr. Whigham?
Hi, everyone. We're also working on some strategies to improve and increase access to obesity care, especially through clinical settings. As you heard at the beginning of our summit today in Dr. Barlow's presentation, making sure families and individuals have access to evidence-based care that is actually prescribed by the leading medical bodies in our country for the best strategies to address the causes of obesity. That's really essential. And right now in our country and in our state, we're not in great shape, but we're getting better. There's new treatments that are available, and we need to make sure people have access to those and can afford those. In the long run, that really helps to decrease overall healthcare costs and increase quality of life and prevent further chronic disease strategies. So one effort that we're making is more on the regulatory side, and we're going to be working with Texas Medicaid to submit a form to ask them to consider changing what's covered under Texas Medicaid. And I won't say more about that right now, but I just wanted to introduce that rather than a legislative effort, this is more of a regulatory effort. I'll turn it back to you, Joel.
Right, well, thank you. Again, we look forward to visiting with you. I'm going to kind of start the conversation off with just a couple of questions that we have. And first one is, what are, and this is, of course, however y'all want to address this in whatever order, what are the challenges to keeping obesity and addressing the root causes on the agenda? In what ways you have been able to keep obesity prevention at the forefront of your work that you and other advocates can learn from?
I can start with one challenge that I see that's kind of across the board, and then I think probably Rachel and Lindsay can speak to more specifics with their specific efforts. When legislators think of obesity as a personal problem or as a lifestyle choice, then their minds kind of shut off to some of these policy-based strategies that can really help increase access to healthier options across the board, whether that's through food, physical activity opportunities, healthcare treatment, both addressing the causes and the contributors to obesity, as I mentioned at the beginning of the summit. We have these physiological drivers that cause the dysregulation of how our body stores energy, how much energy we burn, how much energy we take in the form of calories. And if we don't address those causes, it's awfully hard to change the trajectory of the disease. At the same time, the environment that people exist in can cause drives towards greater dysregulation of that energy balance. And so we really need legislators to think in terms of this big comprehensive picture that this is a disease with causes and contributors. And if we're moving forward with bias and stigma against the people who experience this disease, we are going to have a much harder time knocking down those barriers and putting policies and regulatory practices into place that can help people who live with this condition.
Thank you, Rachel. Yeah. Lindsay?
I was just going to tack on to that a little bit. Yeah, I had a legislator tell me last night, you can't change people's eating habits. And so I thought that was a really interesting thing, because we've absolutely seen that you can. And the thing that we implement at Legacy, so just to kind of describe what the program actually is, we have a Legacy Health Connect program. We have 50 AmeriCorps individuals that screen individuals for food insecurity, utility insecurity, that's a big one, as well as housing insecurity and transportation insecurity. The highest one we see is food insecurity. And so when we enroll these individuals that qualify for the program, just through BMI, AO1C3, or diabetes, when we bring the food actually to the community, they are using the food and they are changing their eating habits. And so we have individuals that have not, we can see we've got some control groups, folks that were enrolled in the program and didn't use it, and folks that did use it. And so we've seen results that absolutely reflect that the legislature is incorrect when they say that you cannot change someone's eating habits. And in fact, we're about to launch a story. We have 34 school-based clinics. There's a child that was 180 pounds, and the dietitian, along with the pediatrician in the school-based facility, was able to help him lose 60 pounds over a 2-year period. These are amazing results that end up being incredibly healthy into adulthood, and those are the kind of things that we're trying to address. And so we have a lot of examples for any individual that does not believe you can change your eating habits. And so I will just say that that's one of the barriers, is just that mindset that Leah was mentioning.
Thank you. Rachel?
I'm going to allude back to what I was saying earlier about it. It's not PE nor health is a tested area. There's not a lot of accountability. So when it comes to the school system and then prioritizing what they need to consider as important, those are two items that tend to come to the top. And so I think a big challenge always, and what we are always trying to work on, is making people realize that the more that we fill a child's tool belt with all the items to include reading, math skills, health skills, physical education knowledge, the stronger that those children will be for a lifetime. And that is not always a priority. We also know that with regards to health, not everybody prioritizes health. And that's a hard thing to try to convince people that prioritizing health is a good step in the right direction to helping us combat a lot of issues that hit our legislators in the belt, and the financial belt especially. So that, I think, is one of the things. I also find it interesting because the loudest people at the table are usually not the people that need it the most. So when we are speaking to legislators and stuff, we have to remind them sometimes, and really quite honestly anyone, that what their dinner table looks like is not necessarily the dinner table of all of our students in the state of Texas. And bringing data that's extremely important and giving them a realistic picture of what our Texas youth looks like is extremely important. So they see the need for trying to address these issues at a very young age in our educational setting.
Thank you. You gave me some good sound bites and a couple of things I'm gonna come back to in a little bit. Second question for y'all is in preparing for the current session, what was some of the groundwork you did to try to get your issue on, whether it be the partnerships agenda or just on your respective organization's agenda? Just to kind of explain that process for those that are joining us today.
I'm happy to take this one first. So we knew very early on, we worked with the Houston Food Bank closely, and they had met with the chairman of insurance, and the chairman of insurance was very interested in this idea of food as medicine, but he wanted to see it in practice. And so we actually had him come out and see the Food RX program happen in practice. So we had a patient that came in, had a high BMI, was prescribed the Food RX program, and then we have the food bank truck that comes, I think 2 times a month, and then they were able to go shopping within the healthy food section of the truck and take home that food. And so he got to interview a lot of the individuals that were at the facility, but also see the line of cars that were around the corner in Houston's East End to take advantage of this program that was directly related to the Food RX program. So I think that was the most effective tool, is always the site visit. I think anyone will tell you actually seeing these programs on the ground is extremely effective. And so that's how we were able to move forward with this individual wanting to file the bill that potentially could be something really exciting that happens this session.
It's a great example. Rachel or Leah?
I'm going to say that probably for us, just working with the partnership on our priorities with regards to health and physical education, we met with our administrators from across the state of Texas that are tapered members and heard from them as to what their issues are and what is going on in their worlds. Obviously, there are a lot of requirements that have come down over the last few legislative years with regards to health and school health advisory councils, and listening to their concerns and trying to make sure that we address those concerns in the next legislative session.
Great, thank you. Dr. Whigham?
Our strategy with regards to obesity care coverage has been broad, and we've been trying to work on what types of approaches might be most efficacious. And there's multiple strategies that can be deployed simultaneously. We've seen that in other states around the country. States like Ohio and Minnesota have made great progress in recent years, for example. But one thing Partnership for Healthy Texas has done in the last about, I guess, 8 or 9 months now, working with Clayton Travis, who's a member of Partnership for Healthy Texas, and also works with the Texas Pediatric Society. Texas Pediatric Society took the lead on working together. We partnered to bring together healthcare providers for a conversation around where the biggest barriers are as they work with patients. Dr. Barlow was on that call. We had some providers from our region who treat both pediatric and adult patients, and some other state leaders who work at the national level as well as leaders in obesity treatment and obesity research. And we got into the details of what happens in the clinic when providers are trying to provide care, the intensive behavioral therapy, pharmacotherapy, surgical solutions, and the wraparound support that goes with all of those. And then Allison McCourse, who's working with Texas Pediatric Society and Partnership for Healthy Texas right now as an intern, did a good job of research for us, pulled together our understanding of where the gaps are with the current state of obesity treatment coverage in Texas Medicaid, and put them together in a memo and sent them to Texas Medicaid to get their feedback. And they encouraged us to submit a topic nomination form. They confirmed that the gaps we identified were real gaps and suggested that we submit this topic nomination form. So that's the state that we're at now. And Joel, I know you've been involved in that process, so if you want to add any to that description, please feel free to do that. But I just want to acknowledge the leadership of Clayton Travis and the Texas Pediatric Society in this effort in partnership with Partnership for Healthy Texas.
Well, thank you. Yes, I think it's, we approach it in every which way we could possibly advance policy, and with evidence-based data, regulatory opportunity arose on this last issue with obesity as Medicaid. And so we realized the legislative process may not be the best. It might be a little bit more time consuming, and this opportunity arose. And there are other partners engaged in that as well. I think MD Anderson and American Diabetes Association. So it's all hands on deck, but was good examples on how to get your policies front and center before the session. A couple of you hit on this earlier on in terms of financial impact data. How have y'all been able to successfully engage maybe some of the business community or other uncommon partners on obesity? And have you been able to make the case for the impact obesity may have on fiscal issues such as employee costs, Medicare costs, Medicaid, and just overall absenteeism? I want to kind of put that out there to see if y'all had any stories to share and best practices on how to engage the business community, because this isn't one of the issues they tend to engage on quite from time to time.
I'm happy to just start with my experience. The business community is an important stakeholder because they are paying for employer-sponsored health plans. And so what we've seen is when looking at food as medicine, when looking at these sort of interventions that are less expensive than your traditional insulin or diabetic medications, things that are extremely expensive, or the outcomes of severe diabetes, we've seen a lot of interest in managed care organizations supporting this kind of concept, and really looking at potentially, do we reimburse for this versus an office visit? And so those are what's it's called in lieu of services. I'm sure y'all are all aware of that, but those are the kind of things that's when employers get involved, is could we ultimately lower the price of insurance when you're purchasing it as an employer? And so we have a lot of managed care organizations that have been very engaged in this type of concept. And so that is the way that I think I see the business community involved the most.
Great. Rachel, Leah?
I'll go. So I think probably for us, the best route that I have ever found is showing absenteeism for school districts. That healthier children can attend school if they have fewer issues with asthma, with obesity, with anything that is causing them to get sick. If they're in school, one, it helps them with their testing scores, which always seems to make certain individuals happy because they're not losing any learning time or instructional time. But the other thing is school districts are paid on a daily attendance rate. So when students are in school, schools are getting funding. And so that is usually the strongest route to go with regards to school district individuals in prioritizing health and physical education, is that keeping students healthy, keep them in schools.
Thank you.
I echo what both Rachel and Lindsay have said. We've seen that as well, both at the school level. Healthy kids are better learners, absolutely. And we have a lot of incentives in Texas to keep kids in school. So for school leaders that can see that connection, it's a big help. And as Lindsay was saying, we also see that through the employers who are paying for insurance, if they're self-insured, there's there's a particular drive. We've seen some real leadership in West Texas, in El Paso, where my center is located, where large employers have come forward with an open mind and willing to try innovative strategies. And this can come both through the insurance coverage, what they cover through their plan, but also through workplace wellness initiatives that they're willing to implement to really help give access to tools that can help employees through the workplace. People spend a lot of hours of their day at work, just like children spend a lot of hours of their day at school. So those are two contexts in which we can really provide some environmental opportunities for change as well. Another big area where I've seen the business intersect with the health in a way that I love to see happen. I love it when there's economic drivers that support health, and that's in the area of food systems. And we've had some great leadership in our region from folks like owners of grocery stores, where they really want to do right by their customers and serve the region well and make sure that the customers coming into their store know about health, have the knowledge, the skills, and the capacity to purchase healthy foods, take those foods home, prepare them, and kind of make some changes towards better health for them and their families. So we've had some grocery store owners in our region who have been our lead partners in developing programs like outreach opportunities and program delivery right in food retail settings, right in the grocery stores where the shoppers are. And that leadership helped us change policy at the county level to implement a healthy food financing initiative. So this is economic development funding that is targeted towards healthy retail. So how do we get access to healthy and affordable foods more broadly spread throughout the county? In our case, this is a county-based policy. So some of our economic development funds in El Paso County go towards projects that are specifically targeting increasing access to healthy, affordable food in the regions of highest need. And we know those regions of highest need because we did a mapping assessment in the county to identify where are the neighborhoods with the lowest income, the lowest grocery store sales, the highest death due to diet-related diseases, and how can we work with community organizations and partners who have innovative, creative ideas to drive change in those neighborhoods to make sure we're increasing access. So it benefits the county, it benefits our economic development throughout the community, but it's supporting, these are funds that go to businesses to drive change that allow them to provide healthier access to affordable food.
Well, thank you. Y'all each provided a segment of the population or the business community that how you demonstrated to them the importance of these policies. That's something I hope our viewers can take away. And I know that I made some notes for some of the policies we're working on, so appreciate that. Dr. Whigham, I'm going to kind of turn this one directly at you. And I think we already kind of touched on it a little bit, but more specifically, how do you communicate with lawmakers and policymakers to explain the need to address both causes and contributors to obesity? And how does addressing that stigma play into the work you've been doing and working with coalitions, lawmakers?
That's a really great question, Joel. It's essential. We see this in efforts across our country that at the root of making policy change is really helping whoever that audience is that's going to help with that change understand that obesity is a chronic disease. It's not the fault of the individual. It's not a moral failing. It's not laziness. Obesity is not caused by eating too much food. Obesity is not caused by exercising too little or watching too much TV. Obesity is caused by an internal mechanism that dysregulates the drivers of food intake and or the drivers of energy expenditure or calorie expenditure. And because of that dysregulation, the bodies of people with the disease of obesity are going to store excess calories of fat. So fat comes as a result of obesity. It's not a result of eating too much or exercising too less. And if we can help legislators understand that, that at the core of this is a physiological driver. Just like at the core of cancer is something physiological inside the body of that person that's driving the cancer. We don't blame a person who has cancer for getting the cancer. We help make sure they have access to the best evidence-based treatments and that they can surround their world of nutrition and activity and other lifestyle factors to improve their chances of survival of cancer. We need to do the same thing for obesity. So we need people to have access to healthy and affordable food. We need people to have ways to move their body in safe, convenient opportunities using active transportation to get to and from school or work, to be able to go out for walks in their neighborhood in a safe and pleasant way. But if we don't address the causes, those internal physiological causes, then all of those factors that influence the contributors to obesity won't help change the obesity prevalence. We're not going to change how many people are affected by the disease unless we can address the causes, and at the same time that we're addressing the causes, make those environmental factors also improved so that people are living their lives in a healthier context through their workplaces, their schools, their neighborhoods, and make those changes simultaneously. So that's really how we try and communicate to legislators, and then bringing in the research they need to make their case. We have a lot of legislative partners who care tremendously about all of these things we've been talking about, but they need partners who can speak to that and provide them the information they need to put together a strong case. And I'd like to call out Deanna Hoelscher and her team at the Dell Center in Austin at UT Health Austin campus, where she's established this research to policy collaboration project where she's pairing researchers with legislators to help ensure that they can get the information they need to do their jobs at the Capitol. And she'll be speaking at the end of our summit, so she'll probably make some more comments on that. She is online with us right now. But I think really facilitating as much as we can that transfer of information to make sure the people who are experts in these fields have access to the data about the impact that these kinds of changes can make, are connected to the legislators, that there's not kind of work happening in silos, but that we're working across these areas of expertise to really deliver the best science into our policy making so that we're impacting lives in a positive way.
Thank you, Dr. Whigham. That was very helpful. Again, a lot of information in that response, and for those that are out there, and I'm sure Deanna will reference it, but the Michael and Susan Dell Center for Healthy Living and that Texas Research Policy Program has a lot of great tools that on their website that our viewers can look at, some great obesity and all kind of different data relating to PE, smoking, etc., that I'm sure she'll reference. But lawmakers are really looking for any type of information. So I think what you shared in terms of the data, the financial correlations, and then understanding, some of these local initiatives, how they impact their home districts, that's important. One area that, we all are very passionate about the policies that we're looking and advancing this session, but there's also that last minute bill that gets filed or amendment that comes up relating, this overall whole child maybe have a negative impact. From all three of you, are there any particular specific defense that needs to be played this session? And what approach would you take to communicating severe impact a bill may have or an amendment may have to lawmakers when you find such a piece of legislation? Any tips or any insight you can give us on what you may? I know this kind of asking you if you have a crystal ball. What do you see coming at us that we need to be ready to play defense on, and how would you do it when there's probably a bunch of folks on the other side pushing it? So I'm going to call out Rachel and have her start with her, and then shake it up a bit.
I think in my experience, usually trying to find out where the issue is coming from is key on playing defense. it depends on the individual that's talking to us and what the issue that they have coming. So I'm going to I'll give an example from the past, which had to do with the CPR bill many years ago. But the biggest issue, or what we were having to defend, was, could it really be done in the schools? What was really the big impact that particular bill was going to have in there? And answering those questions clearly and logically is usually the best route to go. Anytime that there is going to be an additional requirement put on school districts or additional requirement put on a business, you're going to have to fight the people who don't want those additional requirements. So that's usually the defense that you need to approach. I think for us in this particular case, it's going to be more of keeping what we have in place and trying to encourage people that, especially our legislators, I think that they have the right mindset sometimes when they put certain legislation in with regards to health education. But I don't think all of them realize that there's really not an avenue to teach those things. And so if you don't have an avenue, then how are these great bills that you're putting in place actually going to get delivered? And so I think educating will also help maybe eliminate some of the need for being defensive.
Thank you. Lindsay?
Yeah, I'm happy to chime in. I think the thing that I'm most concerned about with the Food as Medicine Act is just the general idea that that it's so important outside of the four walls of the exam room to address individuals' health. And so because if you look at federally qualified health centers, we're all in underserved communities, and that generally maps right on top of food deserts. And so when we bring the food to the clinic, it's a huge asset for the underserved individuals. And so I think just making sure people understand that you may be a legislator, but you might not have ever missed a meal in your life. You might have never been on, Medicaid or food benefit programs or things like that. And making sure that people understand that this is a very large portion of a population that really does, we can change health outcomes. And so I'm hopeful that legislators will absolutely see this as an asset. But that's the one thing I am concerned about is just a general, now that has nothing to do with healthcare. And so the way that you fight back on that, I think, is you bring the science and data that you are all talking about, that Dell has created, that UT has created, the Rockefeller Foundation, Episcopal Health. There's so many individuals moving in this sort of highway of what healthcare is, that I'm excited to present the data and to have a lot of support. I think both from when insurance companies and providers can agree on something, it's always a really exciting movement in healthcare. And so I'm hopeful that all of us can sort of move this forward as an agreed upon. And again, it's a pilot, it's not a mandate. These are things that we want to study. And I think it's important that the state start to study it as much as the public institutions have.
Great, thank you. Dr. Whigham?
Well, I think, Joel, you already kind of highlighted some of the defense priorities for Partnership for Healthy Texas, and I'll just emphasize again how important those are. We don't want to slide backwards when it comes to things like changes we've made. Texas really is ahead of the game when it comes to things like physical activity within schools, understanding how physical activity is impacting children in schools through tools like FitnessGram. We also don't want to limit the power and the opportunity for SHACs to really play a strong role. Our school health advisory councils, those are intended to be ways to engage parents in the health of their children through the school districts. And so we don't want to put restrictions on how SHACs function. We want to support SHACs and strengthen SHACs, because that's really how we get change at the community level. And that's where we need this change happening. some things just can't be legislated and passed down. It has to be driven by the efforts of the people involved and tailored to meet the needs of those populations. And I've seen shacks in our region in West Texas do some really powerful things, but I've also seen when restrictions come in, it makes it that much harder to make those shacks function. They're functioning already with administrative support from school districts that are stretched thin, and with parents who are already, you know, working full-time jobs and trying to manage a family, and they want to be able to engage and participate in shacks. So anything we can do to support those will be great. And certainly on the food access side, you know, we don't want to be limiting things like SNAP benefits. We want more people getting the access they need and opportunities to help drive what causes the need for SNAP benefits, what drives people to food pantries in the first place, what kind of programs, evidence-based programs can we put into place. I mentioned one in the earlier hour that's been demonstrated in our community to be very effective, the Fresh Start program, where we work with people to address the root causes of hunger so that they don't need to keep going to the food bank or the food pantry to receive food, but are addressing the drivers of that food insecurity. When people live in food insecurity, as Lindsay has already so beautifully articulated, the food insecurity itself drives physiological changes that make health worse. It's not just about someone not having enough food. Conceptually, I think people who don't experience food insecurity, that might be how they see it. But the stress that builds within a person's body when they're worrying about how are they going to put that next meal on the table for their children, the stress that drives the inflammation, that drives insomnia, that sleep deprivation makes those health effects even worse. All of that is this vicious cycle that makes the overall health worse. So that food insecurity can be a trigger that perpetuates chronic inflammation and other markers that are going to drive increased adipocyte formation in driving central obesity, which then drives up all the factors that influence things like metabolic syndrome and drive heart disease and so forth. So all of these things are integrated. You know, the stress in the world around us ties directly to how our body functions. And so anything we can do to ensure we're not limiting access to these programs that are there to help people, I think is really important from a defense perspective.
Well, thank you. We'll have one more question for each of you, and time permits, we've got a couple in the chat box, but for the audience out there that's joining us today, what's the best way for them to get involved this session? We're already, March 1st today, the session ends, regular session will end at the end of May. So between now and then, what are some tips or suggestions on how the audience can get involved if they'd like to get engaged on some of these policy initiatives?
I'll start out on that one. I think the key is knowing who your legislators are in your area, making sure you tell your story. As we share with our members on a regular basis, advocacy is not always in the halls of the Capitol. Advocacy starts with grassroots. It starts with your programs in your schools. It starts with things that you're doing in your community. It starts with success stories that you hear with regards to someone's health success. So those are the things that you easily, everybody's into social media, put your story quickly with a great picture on social media, tag your legislators. The more that we make them aware of the impact that health has on people and physical activity has on people, the better off they're going to be. They attach themselves to stories. Stories stick and resonate with people. And so that will help kind of bring along that story. We're really pushing for our members to share the successes that they're having in their school district. If you have events, invite the legislators, make sure that they're coming. They may not attend themselves, but they might send somebody that's willing to come. Just making sure that we're sharing the positives, and it's not always the negative that's getting shared with them.
Thank you.
I will also add.
I agree with that.
Oh, sorry.
Go ahead, Lynn.
Rachel, you're absolutely right. It's not always done in the halls of the Capitol. I think, look, we have these bill hearings, then you have to come to Austin, You may have to wait hours to testify. Those are absolutely effective, but also emailing your legislator to say, please support this is really important. So I can't say enough about, yes, it is important to gather a group. You don't want 100 people testifying with the same testimony. That's never that effective. But at the same time, 100 people emailing your representatives, that's a really powerful tool to say, please support this bill. This is what we love about it. This is my story, as Rachel was saying. So it can be done. Advocacy, really important advocacy, can be done outside of the halls of the Capitol as well. And since we're in such a time-sensitive environment, it's really important that you communicate now what your priorities are for this session.
Thank you, Lindsay.
I support everything Lindsay and Rachel said, and I will just add an even more specific plea, if I could, for any of those healthcare providers on the webinar today or listening to the recording afterwards. You carry a certain amount of respect and authority in your individual communities. As a healthcare provider, others look to you as an expert when it comes to health. So the more you can convey the message that when it comes to obesity, this is a medical condition that needs to be treated in a medical context. In addition to changes in the community, in the whole environment, we need healthcare providers who have access to training so they know how to deliver the care, but who also have the ability to get reimbursed. They can't spend their time doing intensive behavioral therapy, counseling their patients, providing that support if they're not going to get reimbursed for it. They cannot survive. Their clinic will not stay open if they give that treatment away for free. Yet right now it's really hard for those providers to get reimbursed. And they are limited in how many treatment options they can offer their patients, because some of the most effective treatment options out there are not covered through standard healthcare plans. So the more you can convey to your legislators, in addition to everything Lindsay and Rachel already said, if you are a healthcare provider, reiterating to legislative leaders that this is a medical condition and it warrants medical care.
That's all great information. Thank you. That is wonderful that you can share some of those tips. Hopefully the folks in the audience can take advantage of that. As we get ready to kind of wrap it up, we do have a few questions in the chat box that I'm going to pose that have been submitted, and I'm going to read the first one. And the question was, what can obesity medicine physicians do to help outside of the clinic setting? So I'll toss that up for whoever wants to grab it first.
Well, I just spoke to that, so that was a great question to tie into the relevance that we really do need those obesity medicine specialists who have that clinical authority and expertise to speak to the need for access to care. So find out, if you don't already know who your legislators are in your region. They love to hear from voters, but I often will reach out to legislators who aren't representing my specific district. If they're from my region, I will still reach out to them and have these kinds of conversations. You can reach out to me directly if you want to get more involved at the state level in speaking for some of these regulatory changes. The more providers we have that can tell their stories of the struggles they face when working with patients, the stronger our case will be. So please feel free to reach out to us through Partnership for Healthy Texas. The organizers of this event will have my email address in the slides and in the online content afterwards. So please feel free to let us know if you want to help with that charge.
Great. Anybody else want to take that? I will move on to the next question that we got was, when you refer to face-to-face interventions, is that recommendation directed to BHS interventions or nutritional interventions or both?
So that was content covered in the first hour of our summit, and those intensive behavioral interventions do include both nutrition interventions, helping people understand nutrition, how to follow a healthy diet. But in order to follow a healthy diet, for a person with obesity to follow a calorie restricted diet for the purpose of achieving a healthier weight, you have to follow that day in, day out for not just a few days, for weeks, for months, and for years on end. To do that, you need to develop behavioral and psychological strategies that make it easier. So there are components within how we shape the nutrition of a diet that can help decrease hunger, the physiological hunger that can drive intake, but you also need to address all those other psychosocial components that can influence our eating behavior. And then those psychosocial components can also help to support finding ways to move so that you are expending more calories, but to do it in a way that's sustainable and fun and enjoyable and feels good to your body. So those intensive behavioral therapy approaches include nutrition and physical activity, as well as psychological and behavioral science that drives how to maintain those healthier behaviors day in and day out. Because a person with obesity, their body is working against them, and just telling them you need to eat more vegetables and sit on the couch less will not work. We've got literally thousands of studies to prove it does not work. They really need support to develop those skills, and at the same time, access to the medical treatment that will help bring down those physiological drivers of the dysregulation of how their body stores calories.
Thank you, Dr. Whigham. One more question, and this one, it looks like it's directed right at me. In working with and leading a coalition with diverse stakeholders, how do you maintain coalition alignment and engagement of all the partners? So our coalition has grown over the years. We pride ourselves in that we've been able to work well together with all our partners and gather their respective priorities prior to each session. We actually do, sit in a room and put priorities on a wall. We've gotten a little bit more sophisticated now. We use SurveyMonkey, and that way we can figure out how to prioritize those priorities. But we also look at, as I mentioned earlier, we assess the legislative landscape. What realistically can we get through the process? Who's going to be our champion? And also, what data and supporting evidence do we have? We create one-pagers for each policy. We also, during the interim, we look at who potentially could come and testify for these issues, or how we can leverage a certain a priority of the legislature to leverage some support for our initiatives. The coalition's been really great about working well together and being nimble. I'll say that in the sense that there may be some policies that we may need to put hard in support, but it may not align 100% with our other priorities. But there may be a couple of coalition partners that have asked for support, and if we feel that the policy is evidence-based, has some supporting documentation that we can share with lawmakers and our respective members, then we do flesh that out through our legislative committee. But our agenda items are fleshed through the legislative committee, and then go through the full steering committee and the full membership and voted on prior to each session. So we pride ourselves, and it's been very inclusive, and we've managed to work with diverse stakeholders and maintain kind of a focus on what our goal is with the addressing of the childhood obesity, but also delving in a couple other areas that we feel we can make an impact. It's been a great ride. I've enjoyed being part of a founding member, but also just being, legislative chair. We've got some great folks, and we are the Partnership for Healthy Texas. Always looking forward to having more people engage with us. Feel free to visit our website at partnershipforhealthytexas.org to sign up for our newsletters if you've not received any. We put out a monthly newsletter. We also share on social media upcoming events, policy opportunities for whether we do legislative briefings or webinars similar to this. So we definitely are looking forward to everybody on this call that was here today to engage with us. I do want to thank our panelists, Lindsay, Rachel, Dr. Whigham, for joining us today and taking time out of your day and sharing with us your focus, your recommendations on policy interaction at the legislature and back in the district, as well as your expertise and your arena in terms of the policies you're each advocating for and providing support for. Thank you for being here today and joining us. And then also, I would be remiss if I didn't share the Tayford, Rachel Nader's our executive director there. They'll be celebrating their 100th anniversary at the end of the year, and they're organizing. You're going to have a Capital Day March 15th. So I'm excited for them and any PE, health, and dance instructors out there. To reach out to Rachel. It's going to be an awareness day, if I remember correctly, but it'll be a good day for anybody that might get involved. And so with that, I'm going to turn it back over to our friends at the Michael and Susan Dell Center.
Thank you so much, Joel, Leah, Rachel, and Lindsay, for the very insightful panel. I have to say that, so many people who are watching today are always wanting to know, how to get involved more in policy and in advocacy. And so you all coming here today has really given them, a contact and an avenue to do that. And I would really encourage all of you to reach out and, reach out to our panelists today with any ideas or thoughts or energy that you have, because it's really the people who are at that table that, they're the ones that are really making the policies that make a difference. So again, thank you all for the really insightful panel today. And so next up, we'll now move into our last segment of our World Obesity Day Summit with a presentation and closing remarks from Dr. Deanna Hoelscher. She is the Regional Dean of the UT Health School of Public Health in Austin. She's also the director of the Michael and Susan Dell Center for Healthy Living. She is the principal investigator of the Texas School Physical Activity and Nutrition Survey, otherwise known as Texas SPAN. And that's funded by the Texas Department of State Health Services, and it monitors the prevalence of obesity in school-age children in the state. She's also the principal investigator of the Streets Project, an NIH-funded natural experiment to determine the effects of safe routes to school policies on child physical activity. And along with her role as the director of the Michael and Susan Dell Center for Healthy Living, she oversees the Texas Research to Policy Collaboration Project. So please join me in welcoming Dr. Deanna Hoelscher.
Thank you, Emily, and I'd like to thank you and Leah and the rest of Live Smart Texas, all those presentations. It always warms my heart to see what's going on around the state, and everybody did such an excellent job of presenting.
Thank you.
And then a big thank you to Sarah Barlow for kind of leading us off, and then to Joel and the panel. So, kind of to wrap it all up with a bow, what I'd like to do is give some final thoughts and then some summary. And so you're going to see some bookend to some of the work that Dr. Barlow referenced, and then also just kind of giving you, again, some additional resources that you can look at. So with the next slide, I'd like to kind of focus. I know we talked a lot about kids, and most of my work focuses on children. So we spend a lot more time talking about prevention than treatment. Dr. Barlow talked a lot about treatment today. But I did want to give you a peek at the most recent data we have. And so we know obesity is high among both adults and children in the US, and it is increasing over time. So you saw some similar data from Dr. Barlow. The red is adults, and then the yellow here is youth ages 2 to 19. So if you look at this further with the next slide, what you can see is Texas has a high prevalence of adults with obesity. So not only is it high nationwide, but it's high in Texas. So the states in red have a prevalence of obesity that's 35% or greater. So yellow is 30 to 35%. Orange is 30 to 35%. Yellow is 25 to 30%. And then green is less than 25%. So these data are from the Behavioral Risk Factor Surveillance Study. And what you can see is, if you look at this with the 2021 data, if you were to look at this map of Texas in 2013, 19 states would be orange and 2 would be red. So that's 10 years ago. 2 states had a prevalence of 35% of people with obesity or greater. If you looked at it in 2018, which was 5 years ago, there would be 9 states that had a prevalence of 35 or greater. And then fast forward to 2021, which is the last round of data that we have, and 19 states have a prevalence of 35 or greater. 41 states have a prevalence of 30 or greater. So most states in the US have a prevalence of 30% obesity or greater. And everybody's anticipating, when the data come out after the pandemic, that this is likely to increase. So with the next slide, we can look at national rates of child obesity are also high. So these are data from the National Survey of Children's Health, and they call parents and they'll ask parents about the height and weight of their children. And these are children ages 10 to 17, so they don't actually measure the kids. So if you look at this, the scale is a little bit different. So the red states indicate a prevalence of 20% or greater of children with obesity. The orange states are 15 to less than 20%, and then the yellow is 10 to less than 15%. So if you look at the states, in 2018, 2019, Texas was just underneath the 20% prevalence, but the newer data just before the pandemic from 2019 to 2020 show that Texas is in the 20% prevalence of obesity or greater. So what you can see is that not only is the prevalence of obesity high, but it's increasing. So it really gives a little bit more fuel to the fire for us to do something immediately. So the next slide shows data from the Youth Risk Behavior Survey. So these are high school students. And what's interesting about this is, as with adults, the obesity prevalence varies by demographics. And so this is showing you differences between male and female, as well as different racial ethnic groups, and also between sexual orientation groups. So it really gives you a preview on where the problem exists at a higher frequency. However, looking at this, it's an issue pretty much across the board. The next slide then shows more Texas-oriented data. So the slide I showed previous was high schools across the US. But just to orient yourself to the slide, if you look at the group of bar graphs, the first one is the percent of low-income children. So this is from WIC. And so these are kids from 2 to 4. And so the orange is Texas and the green is the US. So what you can see is the prevalence of obesity among children in WIC is higher in Texas than in the US. If you look at the middle group, the middle bar graphs, you can see this is from the National Survey of Child Health. So what you can see is the prevalence of obesity in Texas is 20.7 compared to 17% across the US in general. And then the last set of bar graphs represents data from the Youth Risk Behavior Survey in 2019. And that shows high school students in grades 9 through 12. And what you see there, again, Texas has a higher prevalence of obesity. So with all of these data, Youth Risk Behavior Survey students are asked to give their height and weight. The middle bar graph, parents are asked to report height and weight. But if you look at the SPAN data at the top, the orange line represents the prevalence of obesity in 2019 to 2020 among 4th grade students. The green line is among 11th grade students, and the blue line is 8th grade students. So you can see that these data that are actually measured in the field, are much higher than what's reported by these different national groups that have Texas data. Next slide. If you could advance it, yeah, and one more time. So what you see here is, again, the orange and the green and the blue representing, the orange is grade 4, the green is grade 8, and the blue is grade 11. So really what you see is in 2000, the 4th grade started above a 25% prevalence of obesity, but it actually dipped down because of all the initiatives that were going on in the state. And then a lot of these initiatives tended to get watered down, and you see the results of that as the obesity rate went back up. So I think what these data show us is that you can reduce child obesity in a large area such as Texas, given some of the initiatives that we've talked about. If you look at grade 8 and grade 11, you see that these go up over time. So we see an increasing prevalence over time. The black line there is our Healthy People 2030 goal, which you can see we're well above. And then the red line shows the NHANES. So this is national data from 2017 through March 2020. So just to let you know, we're collecting data right now in SPAN. So I just want to give a shout out and thank you to all our partners who've helped us and all the schools that are participating. So we will have data from 2022 and 2023 probably at the end of this year. So it'll be interesting to see what's happened since the pandemic, because the last data we have is immediately before the pandemic. Next slide. Dr. Barlow highlighted this, but she talked about the trends in severe obesity among US children, and this just maps it a little bit more clearly, with the last point being at 6.1% prevalence of severe obesity. So if you go to the next slide, that's US data, this is the Texas data, and if you could advance one more time, the red line there, and maybe one more time, the red line there shows the NHANES data, so the 6.1% prevalence that I just highlighted, but you can see the prevalence of severe obesity among children in Texas, and it's higher than in the US. And again, you can see that it's 10% prevalence or higher for 2nd, 4th, and 11th grade students. So that really will present an issue, especially in terms of what Dr. Barlow talked about and implications for treatment, and then for population level prevention. Next slide. So one of the reasons we talk about obesity so much is because it leads to excess cost in the medical system, in healthcare. And that's something that affects all of our pocketbooks. So one of the things my son said to me the other day, he's a senior in college, and he says, you know, sometimes you just have to tell people about the economic consequences of actions. And I thought, wow, you know, he's really getting it early. So this is showing what it is, the excess cost of obesity for both children and adults. So what this shows is, if you look at the yellow type, that shows the excess cost of obesity in healthcare expenditures per person per year. So children is on the left, adults are on the right. If you look at the severe obesity, which is in the orangish red below, it's very much higher and you can see the total cost in terms of billions. This is really going to be a problem for us in Texas because 1 out of every 10 children in the United States lives in Texas. So what happens in Texas really influences the rest of the US as well, both with children and with adults. Next slide. So where do we go from here? And so you're going to hear some familiar themes that have gone through today's seminar. So these are some recent efforts that can help. So the next slide, there's actually been a lot of movement, which is very exciting. So the White House Conference on Hunger, Nutrition, and Health was held in September 2022, so last fall. And so there are 5 pillars of this. And what's exciting about this is several different healthcare organizations, companies got together and said, this is what we promise to do as part of this conference on hunger, nutrition, and health. So there are 5 pillars here. So the first pillar is improving food access and affordability. So we've heard that in both SNAP access and then increased school meals, which we haven't heard a lot about today. But school meals, especially for kids who are lower resource, they tend to help with weight regulation. The other pillar, the second pillar, is integrating nutrition and health. And this ties really into our previous panel. So what they're talking about here is food as medicine. So the food prescription program fits into this category. Medicaid and Medicare access to nutrition and nutrition counseling. So how do you connect healthcare and community resources, especially for food insecurity? And then medically tailored meals. So this is a very exciting area where you actually prepare healthy meals ahead of time and take them to people that have conditions such as diabetes or kidney disease. The other part of this is really getting nutrition education into medical schools. So this is being done across the state. UT Southwestern has an effort. We're working with McGovern Medical School in Houston. Del Med also has an effort going on. There's an effort in San Antonio. So really looking across these medical schools and how do you integrate nutrition into the curriculum? As you saw with what Dr. Barlow said, the intensive health and lifestyle behavior interventions, a lot of them incorporate the use of food as medicine. So teaching parents how to cook, teaching children how to cook and prepare healthy meals. The third pillar is empowering all consumers to make and have access to healthy choices. So some examples here are front of pack labels that make it easy for you to look at the front of the package and see what foods are healthier. The other thing is expanding fruit and vegetable incentives for SNAP. So double up food bucks is what you've heard from Joel's presentation. The fourth pillar is supporting physical activity for all. And so not only implementing the physical activity guidelines for Americans, but also connecting to parks and outdoor spaces. And we have a lot of those here in Texas. And then the fifth pillar is enhancing nutrition and food security research. So really improving metrics so that we can compare across studies and advancing nutrition science. So next slide. So also USDA has undertaken several initiatives. So they've adjusted the amount of food for the Thrifty Food Plan that's used to determine benefits for SNAP recipients. But one of their biggest initiatives is the focus on nutrition security. So we know that people who have food insecurity are more likely to have overweight or obesity. And so how do we get them consistent access to not only affordable food that's consistent, but also foods that provide optimal health, and also foods that are culturally sensitive. So foods that they're used to consuming. there's a lot of different ways for people to consume a healthy diet. Healthy diets are found in every culture. So how do we personalize this and make it healthier and make sure people have affordable food? So a lot of these different initiatives that are being worked on now talk about supporting all stages of life, connecting Americans to healthy, safe, affordable food sources, and then kind of translating this into the nutrition science findings into action. And then finally, prioritizing equity. So making sure that we're equitable in terms of food access. Next slide. So getting around to prevention of childhood obesity, we've heard several ways in which we can do this. This was a systematic review. It's an umbrella review that we did that was published last year with the Academy of Nutrition and Dietetics. And basically for 2 to 5-year-olds, we found that interventions in the home and family, healthcare and community settings were effective in child obesity prevention. In elementary school kids, school interventions and then regulated screen time were effective. And then for children and teens, it's nutrition with physical activity interventions, multi-component interventions, and policies that improve access to healthy foods. Where we still have some research gaps include e-health, m-health, and telehealth. There's several studies underway, but we don't have that body of evidence yet. Kind of the effect of food access over time and diet quality, which again, there's a lot of work being done in that area right now. And then for adolescents, in terms of prevention. So Dr. Barlow focused on treatment. I'm focusing more on prevention here. Next slide. So a few of evidence-based policy options, and several of these we've heard, several of these reiterate what Partnership for a Healthy Texas mentioned. But one is continuing universal free school meals, or in Texas, making sure that all schools that qualify get the community eligibility provision. So a lot of schools in Texas qualify for free meals given the communities that they're located in. The second one is prioritizing physical activity during the school day. You've just seen what I've talked about schools can be effective in obesity prevention. Kind of related to that is ensuring that Texas residents have safe and convenient access to walking and biking trails, and that all students have safe routes to walk or bike to school. So one of the things we found with our Austin work here is a lot of the older schools in particular are not especially cited to promote active commuting. So that's something we would like to change. A fourth option is increasing SNAP access. So this is something you've heard about through the vehicle assets test, and then expanding college student SNAP eligibility. So next slide. Expanding access to healthcare. And what I mean here is what was referred to both by Dr. Barlow and then in the panel discussion about Medicaid covering U.S. Preventive Services Task Force A or B recommendations. So currently those aren't covered, as Dr. Barlow said. So that's really something that we would want to see covered, both for children and adults. There's also a lot of economic incentives. So one of the ones that I've listed here is a new markets tax credit. And so it incentivizes taxpayers to invest in low-income communities that lack adequate access to capital. And there's an example of in Washington, D.C., where they transformed a parking lot into a community facility with a rooftop garden and fitness center in a low-resource part of town. So there's an example of what you can do with economic incentives. So as you heard before, preventing weight stigma is really emphasis area for us. And one of the ways to do this is really emphasize weight bias training for healthcare professionals across the gamut. Nutrition education and early care and education for parents is another evidence-based policy. So really getting nutrition education at that point of care, and parents are usually very receptive to it at that age. Addressing foundations of health, such as food insecurity, housing is another one. When people have to make a decision about whether to pay for housing or food, that's not a good decision any way you look at it. Increasing access to healthy foods. So the Double Up Food Bucks, which you've heard of, and then healthy food financing initiatives. So several of those are ongoing, especially in the El Paso area. And then one of the things that was brought up recently is we've talked a lot about marketing of foods, but one of the things that's a little bit more insidious now is digital advertising, especially to children and teens. And so where you have influencers that really kind of promote certain foods that might not be healthy. So next slide. So as Joel mentioned, we have a lot of resources that show the scientific basis for a lot of these recommendations, and then state level data. So you can scan here to view our legislative initiatives as part of our Texas RPC project. So the next slide. We also have a lot of child health data. So you can scan here to look at these brief, concise reports. So it's on food, physical activity, sleep. We will be updating these in the fall when we get the new SPAN data. Next slide. And then we have a SPAN interactive website. And what's really nice about this is we're being very transparent about the data that we've collected over the years. So these data are from 2000, so you can pick an area and look at it, or pick an indicator and look at it across time. Not all indicators are at all time points, but it's kind of fun to peruse that and look at changes in diet and physical activity over the years across the state. And then for some years, you can look at border versus non-border areas. Next slide. So I just wanted to give a shout out to our partners at UT Austin. So if you happen to be in the Austin area, Jamie Ard, Dr. Ard is giving a public lecture tomorrow night about Are We There Yet? Driving to Health Equity in the Treatment of Obesity. So he's the incoming president for the Obesity Society. And then he also has a science lecture on Friday, March 3rd. So these are in-person lectures, so you need to be in Austin, but I would encourage you to look at these lectures. They'll really be great. The other thing I wanted to point out is we will be having, we're partnering with Texas Pediatric Society for a webinar on policies, especially related to food insecurity at the state level. So that will be on March 9th. So we'll be sending more information about that. So finally, I'd just like to again give a shout out to everyone who joined us today, and just a little bit about the Michael and Susan Dell Center for Healthy Living. Our vision is healthy children in a healthy world. And you can't have healthy kids without healthy parents and adults and communities. So we kind of build it out with the focus being the child. We also advance health and healthy living for children and families through research, innovative community-based programs, and dissemination of evidence-based practices. And with that, I'd like to thank you, and my contact information is there. And I'll turn it over to Leah and Emily.
Thank you.
Thank you so much, Deanna. Great presentation, great bookend to our World Obesity Summit. And I want to thank Deanna not only for her great presentation, but for hosting us through the webinar platform. that she has here at the Michael and Susan Dell Center for Healthy Living at UT Health Houston School of Public Health Austin campus. And thanks for hosting me personally in person in Austin today. Really appreciate that. And I would be remiss if I didn't give a big thank you to Sarah Bentley, who's behind deriving the whole webinar today, managing all the technical glitches that pop up and getting all the speakers coordinated. So thank you so much, Sarah. Emily, I'm going to turn it over to you right after I say thank you to Emily for co-chairing this session with me today and for all your partnership, not only with Live Smart Texas, but with all of our collaborative efforts to address obesity throughout the state and across the nation. Emily, to you.
Yeah, thank you, Leah, and thank you, Deanna, for giving us an overview of what, a tremendous resource that you have built, and the Michael and Susan Dell Foundation is just like a real hub and center for the whole state, and such a tremendous resource. Thank you so much for giving us a great overview of all what you all make available. And lastly, everyone in your audience, in our audience, thank you for being here today. And thank you for making World Obesity Day a time when we can all come together and really take stock of the work that we're all doing. It's really exciting to hear about all of it, and I'm just really proud to have been a part of today. So thank you again. Bye. Take care, everyone.